Good afternoon and welcome back from the lunch. I hope you all enjoyed your lunch. And I believe you must have had your coffee as well, so that you can keep awake after the lunch. So we are starting with the next session, which is session 6, cardiovascular metabolic kidney syndrome. And this session is directed by Dr. P.K. Gupta. Please welcome. And chairpersons and moderators for this session are Dr. Selvin George, Dr. V.K. Mishra, and Dr. Georgie Koshi. So Dr. Georgie Koshi could not make it in person. So we'll have Dr. Gupta, Dr. Selvin, and Dr. Mishra. Thank you.
Good afternoon, ladies and gentlemen. We have got a session on cardiometabolic health, which is including the 3 topics and a topic on prevention as well as on imaging. So I will start with cardiometabolic health, and I'm going to speak on pharmacological management of cardio-kidney metabolic syndrome, current options and future directions. So let's start with a case. Here is a 56-year-old gentleman who is an obese, diabetic, hypertensive, dyslipidemic, has got worsening kidney function with eGFR of 55 and UACR of 320. His LDL is 146 and TG of 165. Wife tells that he snores and he has got osteoarthritis knee, and he reports of fatigue and shortness of breath. So if you really analyze and list all his problems, he has got clinical obesity, multiple metabolic uncontrolled risk factors in the form of diabetes, hypertension and dyslipidemia. He has got CKD stage G3A-A3 as per CADIGO 2024 guidelines, osteoarthritis knee, obstructive sleep apnea, and cardio-kidney metabolic syndrome is stage 3. He is on insulin and oral antidiabetics and presented with shortness of breath and fatigue. So let's start with what is CKM. As you have already heard earlier, that this is a health condition in which cardiac disease, kidney disease, obesity and metabolic diseases, they are connected, leading to poor health outcomes. And if you really analyze and see that as per ACC-AHA 2023 Presidential Advisory, the construct which they have provided in stage 0, there are no risk factors. Stage 1, when there is a excess dysfunctional adipose tissue in the form of abdominal obesity along with the impaired glycemia. Stage 2 are multiple metabolic risk factors in the form of diabetes, hypertension, metabolic syndrome, hypertriglyceridemia along with moderate to severe kidney disease. Stage 3, subclinical CVD in the form of atherosclerotic CVD as well as subclinical heart failure. And stage 4, clinical CVD in the form of MI, stroke, peripheral vascular disease, heart failure and atrial fibrillation, along with the severe kidney disease. So what are the things which we have to analyze in this patient? How much is his risk? What are the goals of treatment and how to achieve them? So regarding his risk, if you see, as per CKM staging, he belongs to the stage 2. And if you look into the CADIGO 2024 heat map, he belongs to G3A as well as A3. And this gives you a very high risk as per CADIGO guidelines. And as per ACC-AHA guidelines, in the CKM patients, they recommend prevent equation to calculate the risk, and here, this is the equation which covers so many things, and it is different than previous calculators. And here you can calculate the total CVD risk, atherothrombotic risk, as well as the heart failure risk. So in this individual, if you see, there is a significant 62% risk 30 years and 10-year risk is 36%. Individual risks are also quite significant of atherosclerotic CVD as well as for heart failure. He was further evaluated. ECG reveals normal sinus rhythm with LVH and LVSP. Echo revealed increased LVMI and grade 3 diastolic dysfunction. His NT-proBNP was 350 and ultrasound abdomen revealed grade 2 fatty liver, and the coronary artery calcium score was 313. So if you put all, he has got subclinical atherosclerotic CVD as well as HAPPAF along with the evidence of grade 2 fatty liver. So he belongs to a very high risk group. How to go back? Yeah. So goals of treatment are prevent the progression of proteinuric CKD to end-stage renal disease and RRT, prevent progression of subclinical CVD to clinical CVD to prevent MACE, heart failure, atrial fibrillation, morbidity and mortality, control of metabolic risk factors as per guidelines, and improve the quality of life by improving the obstructive sleep apnea and osteoarthritis knee. So how to achieve them? Of course, you have to implement lifestyle intervention by lifestyle essentials, which includes 8 to 10. Regarding the treatment for shortness of breath, he was given diuretics. For proteinuric DKD, we can use RAS inhibitors, SGLT2 inhibitors, finerenone, that's a non-steroidal MRI, and GLP-1RA. For HAPPAF, SGLT2 inhibitors are class 1A recommendation or across the spectrum of EF, finerenone as per Fine Heart's data, and GLP-1RA as per STEP, HAPPAF as well as SURMOUNT trial. For coronary artery calcium, you have to keep the LDL less than 50. You have to use statin plus non-statin along with a single antiplatelet therapy, and control of metabolic risk factors for diabetes, HbA1c less than 7, including SGLT2 inhibitors and GLP-1RA. Hypertension, antihypertensive therapy should include RAS inhibitors with BP aim of 120 to 130 and 70 to 80. For weight reduction, GLP-1RA, and for dyslipidemia, statin plus non-statins. Life Essentials 10, you are all familiar. I am not going to repeat it. I have just added 2 more, that the positive family and social interaction and away from air pollution. These 2 new has been added. So for prevention and treatment of CKD in diabetes, these are the 4 pillars. RAS inhibitors, SGLT2 inhibitors, non-steroidal MRA, these all 3 have been included in KDIGO guidelines, and GLP-1RAs have been approved for the similar indication in January 2025, so that has not been included in the guidelines yet. Regarding the HAPPAF, for congestion we use diuretics, SGLT2 inhibitors are class 1, finerenone as I have said by Fine Heart for data, and GLP-1RA for HAPPAF DM, HAPPAF obesity and SURMOUNT trial. For coronary calcium score, as per LAI, coronary calcium score beyond 300 belongs to the extreme risk group A, and LDL target is less than 50, optional target of less than 30. For diabetes, these are the ADA 2025 guidelines, as the patient has got subclinical atherosclerotic CVD along with the heart failure. So he has to be on both GLP-1 as well as SGLT2 inhibitors. That will help in reducing the weight as well as controlling hyperglycemia. For blood pressure, ESC guidelines recommend the goal should be less than 120 to 129 and 70 to 79 for this patient. So, ladies and gentlemen, in 2025, we have got these 4 pillars of the management of CKM. That's the RAS inhibitors, SGLT2 inhibitors, non-steroidal MRA, and GLP-1RA. But if you really analyze the whole spectrum of the cardiometabolic health, as such, is maximally covered by GLP-1RA than the other pillars, as shown by in this slide. If you see whatever the patient has, obesity, diabetes, hypertension, dyslipidemia, CKD, osteoarthritis knee, CVD, MASLD, OSA, all have been positively modulated by GLP-1RA. For OSA, they have already been approved by FDA. For kidney, they have already been approved by FDA. For CVD, they have already been approved by FDA. And in a lot of other things, already the trials are on. And if you see, by 2030, these are the drugs which are going to explode. We have got currently the injectable 2 semaglutide and tirzepatide, and oral semaglutide. There are 3 more oral drugs are in the pipeline. Combination of GLP-1 and GIP. Tirzepatide is already in use and so many other in the guidelines. And GLP-1 and GIP and glucagon agonist triple combination, retiropatide. It will be available in 27, 28. We have got the combination of GLP-1 and glucagon, survodutide, and GLP-1RA plus amylin is the CagriSema, and the trial is already going on, and we are participating in that. So we will have so many drugs. And if you look in the retiropatide triple combination, reduces weight by the tune of 25%, and that's equivalent to metabolic or bariatric surgery. So on a lighter note, if you really see, instead of CKM, it should be CKRLM syndrome: cardio, kidney, liver, reproductive health, metabolic syndrome, CKRLM syndrome. So if you really see, it is the obesity leading to diabetes, hypertension, dyslipidemia, interaction of CKD, MASLD, and CVD. And in reproductive health, we have got the PCOS, POI, and male functional hypogonadism and obstructive sleep apnea. So, ladies and gentlemen, by 2030, we expect a lot of these drugs, and hopefully the prices will come down. So, we will have better reduction in stroke and heart attacks. People will eat less on these drugs, so they will have more money in their wallets. Airlines would be happy as they will be flying lighter individuals and saving millions of liters of aviation fuel. And people will enjoy the better physical, mental health, and good quality of life. So I will finish off that death is inevitable, but premature death is not. So implement GDMP in CKM syndrome and improve the quality of life and prevent premature death. Thanks for your kind attention, and thank you.
Thank you, Dr. Gupta, for a lovely talk, which is giving a new phase of management, and one has to be very careful while dealing with the different drugs, their interaction, and not to harm the kidney. We will have the question in the late, but one question I will just ask. Every patient is asking these days, what is the main reason, apart from comorbid condition, people having an early renal failure or early renal damage? Is it something in the food, something in the drug, something chemicals, environment? What is the first or 3 points you will highlight?
See, basically all these things are linked, and the key of linking all this is inflammation. Inflammation, if you just talk about the heart, epicardial adipose tissue inflammation leads to myocardial fibrosis, HAPAF. The perivascular fat leads to inflammation, leads to accelerated atherothrombosis. In kidney, inflammation leads to glomerulosclerosis, fibrosis, and CKD. In liver, the inflammation leads to fibrosis, MASLD, cirrhosis, hepatoma. So it's the inflammation which links all. And these drugs are very potent anti-inflammatory and leads to significant reduction in the visceral adipose tissue along with the hsCRP. And that's why they improve the function of all the organs.
Thank you. Thank you for the update. Now, yes, I would like to invite the next speaker, Dr. Rupesh Singh, tracking the triglycerides. Dr. Rupesh Singh, all right. Dr. Rupesh Singh, an interventional cardiologist in a Medicare hospital, Sharjah, and he is one of the daring cardiologists start taking all complicated cases. That's a good point for him. Please, Dr. Rupesh.
So, good afternoon, everybody, and thanks, sir, for the kind introduction. So, today my topic is tackling the triglyceridemia, because which is very, you can say, day-to-day practice, very common thing we come across. But what are the evidence-based therapy for this condition that I am going to discuss in the coming few slides. So, as we know that triglyceridemia is defined as a TG level above 150 milligram percent. Mild to moderate is when the range is between 150 milligram percent to 500 milligram percent, and severe when it is more than 500 milligram percent. In severe triglyceridemia, chances of pancreatitis is much more, particularly if TG level is above 700. There is a good number of studies clearly demonstrating that TG per se is not related to atherosclerotic cardiovascular disease, and it is triglyceride-rich lipoproteins, TGRL, that means VLDL and the IDL, intermediate density lipoprotein, lead to increased risk of the ACVD. TGRL particles are small in diameters and they can cross the endothelium and they contribute to the retention to inflammation model of atherosclerosis. TGRL can be easily measured in your lipid profile by either measuring ApoB, which is most best marker you can say, or by just calculating the non-HDL cholesterol. So all non-HDL cholesterol is a component which contains the TGRL. So what are the causes? There are some primary causes and secondary causes. Primary means when there is some deficiency in the particularly due to genetic mutation leading to dysfunctional lipoprotein lipase or hepatic lipase, because these two molecules mainly lead to the clearance of chylomicron in the bloodstream. And secondary causes, there are a lot of causes, but mainly the obesity, metabolic syndrome, diabetes, alcohol intake, and hypothyroidism, CKD, pregnancy, particularly in third trimester. And these are the, you can say, our day-to-day practice. And some medicines are also important causes of the TG, high TG, like corticosteroid, oral estrogen, tamoxifen, thiazides, and non-cardioselective beta blockers and cyclophosphamide and these things. So whenever patient come, you have to see whether they have any secondary cause of the hypertriglyceridemia, because it is easily treatable cause and you can do the treatment by just avoiding these things. So what are the evidence-based management of hypertriglyceridemia, which I am going to concentrate. So this is the algorithm for the treating the triglyceride. As you know, the patient who is having TG more than 150, try to achieve non-HDL HDL goal by implementing lifestyle modification and treat all any secondary cause if it is present. If still TG is high, between 150 to 500 milligram, just see whether they have any ACVD or diabetes with +1 risk factor for the ACVD. Then the therapy is intensive lifestyle modification and lower the non-HDL cholesterol by statin. So first therapy for even hypertriglyceridemia is the treating statin to reduce the non-HDL cholesterol, and if goal is not achieved, then add the EPA. If they have no ACVD and no diabetes, then just only lifestyle modification and again treating the non-SDL cholesterol level by statins. No role of fibrates, no role of omega. If it is more than 500, then obviously you have to treat for the reason for to prevent pancreatitis. And here the role of, you can say again with the lifestyle modification, very low fat diet, fibrates and omega comes here. But between this level, which is the, you can say 90% patient who we do in our day-to-day practice, no role of fibrates, no role of omega. Coming to some detail about the fibrates and this thing. So in fibrates, all recent trial, field, accord, prominent, failed to demonstrate benefit of fibrates. Be careful about this line, fibrates when used on top of statins. So if you are using statin and giving fibrates, there is no role of this molecule because there is no benefit of this. Earlier trial, why it is still fibrates are using? Because earlier trials, fibrate like we hit and the Helsinki heart study, when fibrates was used without statin, shows some minor benefit. So that why still the many people are using fibrate, but top of statin, fibrate has no role. So what is current status? Only recommended for the when TG is above 500 milligram per. Coming to omega, which is again very popular medicine. So all trial recent after 2020, Origin, Ascent, Vital, Omemi and Strength trial fails to show any benefit of omega-3 in the high risk patients. In contrary, they leading to more having the patient have paroxysmal AF and more chances of bleeding. What is the current status? Only when TG is above 500 in combination with fibrates, you can. Now, another important molecule which for last, you can say 5-6 years available, EPA alone, evaporate, gel it and reduce it. Reduce is the most famous trial happened like 5-6 years back and demonstrated benefit of EPA in the high dose in high risk patient in reducing primary endpoints because only this omega like alone EPA has shown the primary ends benefit. But remember, it happens irrespective of the low LDL or high LDL when at the baseline, irrespective of TG level achieved in the trial and whether TG was more than 150 or less than 150 in this trial. So 10% of in the reduced trial, the TG was less than even 150, but still benefit happens. So what is the best correlation between the effect of this molecule and the outcome was that most important correlation was the level of EPA achieved in the blood rather than what LDL achieved or what LDL was there at the baseline, what ApoB was there, what TG was achieved after the medication. It's nothing related to the outcome. Outcome was just related by the EPA level achieved in the trial. So mechanism is beyond the TG level reduction. It is not just TG reduction medication. It is basically secondary prevention medication, which works in the high risk patient. What the status, what recommendation is there? Recommended is high risk of the ACVD patient with the TG level between 152 to 500 despite statin and the lifestyle mod. Again, despite statin and lifestyle modification. What are the future therapies which is in the pipeline? As we know, the lipoprotein lipase works mainly in the clearance of triglycerides lipoprotein. And these molecules, apolipoprotein 3, ANGPTL3 and ANGPTL4, basically inhibit the lipoprotein lipase complex. So there is a lot of molecules which are coming to prevent these molecules, so enhancing that lipoprotein lipase activity. So these are the new molecules. Basically, they are small interfering into either RNA or antisense oligonucleotide inhibitors. And so basically, among them, only the Volnisiran is approved in Europe, not by FDA, for the treatment of hyperchylomicronemia because to prevent the recurrent pancreatitis. But still, it is not approved in FDA because it leads to a lot of thrombocytopenia. So in conclusion, TGRL, like triglyceride-rich lipoprotein, are implicated as a risk factor of atherosclerotic cardiovascular disease. Statin is the primary therapy for hypertriglyceridemia to achieve the non-SDL goal. EPA can be considered for high-risk atherosclerotic cardiovascular patient who is having TG between 150 to 500 milligram percent despite maximum tolerated. Thanks, and then I think floor is open for question.
Thank you. Thank you, Brajesh, for highlighting the importance of tracking the triglyceride. And that definitely EPA has shown beneficial effect in Julius trial, in evaporate trial, and it is the only one which has shown benefit in controlling varicose vein. I'll give to the for the next biscuit. Thank you.
Thank you, Dr. Rupesh. I think we will hold the questions till the end. Yeah. So our next speaker for this afternoon.
Yes, Dr. Brajesh will present the momentum. Memento to Dr.
So for our next presentation, let me introduce our next speaker. That's Dr. Ijaz Yasmin. He is a consultant endocrinologist from Medcare Hospital, a very good colleague of mine. He supports our Department of Internal Medicine also. Today, he's going to talk about something different. It's more technology based. So something that he's been using many times, and it's called AirDoc. So what is AirDoc? It's a novel handheld fundus camera for CV risk assessment. Something probably most of us are not aware of, but he's going to let us know more about it, and let's look forward to his presentation.
Thank you, all of you, and I welcome you all and thank my colleague for introducing me. When it comes to AI, we all are saying I'm in AI, but do we really know what AI is? Somebody has rightly said that AI is a tool. The choice, how it gets deployed, is ours. So let me take you through this AirDoc fundus. How is it working? Okay. So we'll detect about, when we talk about chronic diseases, we talk that we should prevent them as early as possible. It's better to nip the evil in the bud. So when we talk about screening tests, these tests should be very sensitive, they should be specific, and moreover, they should be non-invasive. So do we have something where we can help our patients to move ahead? When you talk about chronic diseases, you talk about diabetes, and you see by year 2021, almost 500 million of people have diabetes. When it comes to hypertension, more than 1.2 billion people have hypertension. So it's a big cost on the exchequer. And so we need something which is very convenient, which is very rapid, and which can be assessed easily by the physician. Why retina matters? We know that retina is your door to your brain. We know that it is the only organ where blood vessels and nerves can be viewed non-invasively. It tells you about your health. That is why where the AI has come in a great way. Let us see this retinal images. We see that on the left side, we have a healthy retina, and we can detect from retinopathy to arteriosclerosis. These early changes can correlate with stroke, with heart disease, and even brain tumor. You can clearly see there's a slide which shows arteriosclerosis, there's narrowing of the arterioles, you see the TR, the retinopathy, with some exudates, you see papilledema, and you see a retinal vein occlusion. So this is what we have to use as clinicians to check our cardiac health and also to see where our diabetes is. Well, I have been using this tool for about 8 to 9 months, and I was surprised to see the results. I did my checkup, and it showed a very high risk of arteriosclerosis. That means I'm at a higher risk, which can be detected early. Very small, 1.5 kilograms, takes 1 minute, the report comes immediately, and the beauty is it can be even operated by non-doctors. We can teach our nurse or technician to work it. It's voice operated, and it introduces you to whole process once you take this image. So how does it work? It works mainly, it tells us, it analyzes the retinal morphology, nerves and vessels, and gives you out risk index And you see the area under the curve, anything above 0.78 is good. And we see results up to 0.85 to 0.95, which means outstanding. This is, there's a lot of data on it, almost 30 million images, certified in 20 plus countries, and it can give you a lot of eye conditions. But when you talk about chronic disease, we talk about heart attacks, we talk about arteriosclerosis, and it gives you the AUC, which is 0.95, which means outstanding. It has been published in a lot of data in the Lancet and Science Bulletin, and the maximum data has come from China. And this China, in this China, this is the data from China in one of the biggest centers, which is considered to be the Asia Pacific's best ophthalmology center. And here you see clearly, if you go on analyzing these areas, when you talk about retinopathy, you talk about neuropathy, you talk about myopia, all these you see the AUC is above 0.79, it goes up to 0.97, which means that the outcome is quite good. Well, again, the data from the deep learning, this is a deep learning algorithm where the fundus photo was used for 10 years. And you see here, what is the main benefit of this? When you're using this camera, it's very effective, it's non-invasive, it's rapid, and it gives you a low cost when you do the ischemic cerebral vascular disease risk assessment. It's compared to the Framingham's risk score. And now we have something where you don't need to put the lab data in it. So this was developed. When you see the AUC, as I told you, more than 0.97, they developed something which worked on the convolutional neuronal network from a medical checkup data. They assessed the 10-year ICVD risk using retinal fundus image. And then this algorithm was validated using an independent database. And this was done in China. And you could see the risk of getting 10-year ICVD very easily. The benefit here, if you can see clearly, it is not a traditional method. You don't need to put a lot of data in it. It's not invasive. It's not time consuming. You don't need to go for the blood test. It's not complicated as the traditional method. Only you need an image of the retina. It's non-invasive, takes 1 minute, and report is generated immediately. So this is how the report comes. So you can clearly see the fundus picture is here. This is the right fundus. This is the left fundus. You can see the vessels. And you can get all the, whether you have any drusen's, you have exudates, you have microaneurysms, you have soft or hard exudates. And it also gives you the degree of tessellation and the type of fundus you have. And moreover, what's more important as a cardiologist, as a endocrinologist to see, this is how the report comes up. Yeah. This is how the report comes up. So you're screening the patient, and we have to see where it fits for the cardiology, which patients we can refer to the cardiology. Clearly, when you talk about the arteriosclerosis risk, if it comes in green, you are good to go. Orange means mild, this means high risk, and this means very high risk. This patient has 75, which means the chance of developing blood pressure is quite high, up to 50.5%. When you talk about the CV risk, if it comes like orange here, yellow, it's 27, means the risk of getting the CV events in the next 10 years is medium to low, around 5 to 10%. It also gives you the sudden cardiac death risk assessment. You can be green, you can be orange, you can be red, and you can be dark red. And all these risks can be assessed. The most important thing as an endocrinologist, we also see the glucose metabolism risk. I have seen patients who come to us with normal sugars, random sugars, and when we do their fundus examination, we had a big time. We did some free, more than 200-300 examinations, and we picked a lot of patients here. And these patients were having high risk. Means suppose you have high risk, the possibility of getting diabetes is around 40%. So this is an important screening tool which we have to understand. So this is a well-controlled blood pressure, but still, before having any frank changes, you can see some arterial narrowing, and you can pick them early. And depends upon the signs of arteriosclerosis, you can easily pick up the early patients, which you can track later on. So when talk about CV risk, there's a strong association between retinal vascular parameters such as AV ratio or the fractal dimension and the occurrence of CV events. So if we do early intervention, we can pick them early before the disease has developed, and we can significantly reduce the burden of ICVD and improve overall cardiovascular health. When it comes to the sudden death, it's very important you have to understand. It also uses the retinal vasculature features and the demographic cardiovascular data and helps to identify patients at risk of fatal events potentially before the symptoms arise. So we have to understand that. And to sum it up, these are the key takeaway messages. This is me performing the examination. It does not need to be me, it can be anybody. So we have to understand the retina is a window to heart. It's very fast, accurate, and non-invasive screening tool. It's ideal for cardiology clinic. I put this slash, it was not there, the endocrine clinic also. Let us detect it earlier together and let us have a good future for us and for our patients. Thank you.
Thank you so much, Dr. Ijaz. That was an eye-opening lecture. So this is basically a machine which uses AI to detect and predict a lot of diseases in the future. So I think this AI is not going to reduce any of our jobs. In fact, it's going to involve a lot more specialists in the future.
Yeah, definitely. So we should go again with Stephen Hawking, who said that if AI develops, human race will go away. So it will not go away. It will develop more. Thank you.
Thank you.
All right, so let's move on to the next lecture, and it would be on effective obesity management, a quick reprisal by Dr. Praveen Kumar Gupta, consultant diabetologist, Delhi NCR, India. Praveen. Back to you.
Thank you, Mithal sir, for inviting me. Today topic is obesity management. From here, na sir? Okay. Effective obesity management. It is a myth or fact. Obesity is a disease. It is a myth or fact. Let us we discuss it. Patient with obesity, it is an iceberg phenomena. Only 1/3 patient diagnosed for obesity. Maximum patient, 2/3 patient are undiagnosed and untreated well. People receiving obesity management, vast majority of patients with obesity remain undiagnosed and untreated. If I will talk about the number, 33% think they are normal, they are not obese, and only 41% patient are diagnosed. What leads to obesity? Generally, we think it's energy imbalance. Energy intake is high, energy expenditure is low, but it's not true. It is a complexity of obesity: genetic predisposition, hedonic hunger, altered gut microbiota, altered gut hormones, and this is due to complex endocrine, metabolic, and nervous system signals that control food intake below conscious level and that are responsible for energy intake. We have three types of eating. Eating for hunger, it is a real hunger. This is governed by, this is homeostatic eating, and this is governed by the hormone GLP-1, amylin, insulin, and leptin. But main problem is with hedonic eating, eating for pleasure. We are eating after lunch or after dinner, like dessert or sweets. And this is only for pleasure eating. Third, executive cognitive function. Decide what to eat. And this executive cognitive function you can govern by the behavioral interaction. Why is tackling obesity very crucial? If any patient have BMI more than 35, 40, what happened? No. If your BMI is increased, life expectancy will decrease. If BMI is more than 35 or 40, you can see only 50% people will reach at the age of 70. If BMI is normal, 80% people will reach at the age of 70. So, BMI should be in normal range. Effective strategy for managing obesity. We all know lifestyle management is the cornerstone for obesity. If it will not work, then we can go for the pharmacotherapy. If your BMI is more than 30, nowadays we have GLP-1 analog, GIP-1, and if your BMI is more than 40, then option is bariatric surgery. But all individuals, regardless of body size or composition, benefit from a healthy, well-balanced eating pattern and regular physical activity. But this lifestyle management, you can reduce only up to 5% body weight. But your BMI is on higher side, better to go with pharmacotherapy and bariatric surgery also. Losing and maintaining weight loss with diet and exercise alone is a constant struggle. We all know weight loss is calorie low, activity high, weight will low. But same time counter hormone work. Its weight gain is very easily because hunger hormones increase, fullness hormone decrease, and metabolism decrease. Due to this, you can regain weight very early. Despite patient best effort, metabolic changes to weight loss promote weight regain. These are the approved anti-obesity management option for weight. Nowadays, we all know these GLP-1 and GLP plus GIP. These drugs are available across the world: liraglutide, semaglutide, and tirzepatide. This last one is GLP-1 and GIP-1. Data shows if you can take this drug for 88 weeks, trial shows 26% weight reduction. And mainly weight reduction is visceral fat. And these are the pipeline drugs. If I will talk about survodutide, it is first GLP and GIP and glucagon. This is in phase 3 trial. We are waiting for this oral tablet semaglutide. This is under trial, 25 mg and 50 mg. And third, cagrilintide with semaglutide. These are in pipeline. This drug will come in 2026. Approach of obesity management. Language matter. Pupil first language for obesity. An individual is not a disease. Don't label patient as a obese. It is very negative impact. It increase negative feeling towards that individual. It influences how that person feel about their condition and themselves. Third, it cause discrimination. So don't label any patient as a obese. 5A approach to obesity management. First, you ask for permission. Can we discuss about the weight? Second, assess their story to determine the goal. Because every patient is individual, you can't generalize the treatment. Advise on management, lifestyle management, behavior, medication and surgery. Then agree on the treatment, agree on goal for a personalized, sustainable action plan. Then assist. Obesity treatment is not 100-meter run, it's a marathon. It will take a time. Still after my talk, can we say it? Obesity is a myth or fact? Now I think we all are agree obesity is a disease. And this is endorsed by World big organization, World Obesity Canada, Royal College of Physicians, American Medical Association, and all. This is Arogya Param Bhagyam Swasthe Sarvat Sadhanam. Health is the greatest blessing. Health makes everything else possible. Thank you very much, sir.
Before time, sir?
Yes, that's really nice. You finished before time and good reprisal of management of obesity, including lifestyle interventions and drugs. Thank you. Thank you. Coming to the last lecture of this session, we have got Dr. Rami Nematullah, Medical Director, Cardiovascular Imaging Specialist, Allied Medical Center, Dubai. And he is going to talk on multimodality cardiac imaging, a case-based approach. Dr. Rami.
Thank you for your presentation. Ladies and gentlemen, good afternoon. It's a pleasure to be here. I would like to share with you a little bit of insight about the ever-changing cardiac imaging, the modalities, the improvements that are happening, and the guidelines that are quite evolving lately. I have no disclosures related to this talk. Of course, I had to choose a subject, a topic here. I cannot cover all cardiology. So the topic I chose was chronic coronary syndrome. So the latest guidelines in during the ESC 2024 last August. So actually it went again to meet the recent guidelines 2021 of the ACC and AHA about how we use the imaging today to best diagnose our patients. In patients with chronic coronary syndrome or non-acute chest pain. But, sorry. That's slow. Excellent. So the definition of chronic coronary syndrome, actually, it's not only the patient with chest pain, is also the patient that had an acute coronary syndrome, a PCI, revascularization by CABG, but is now stable, but is also the patient that is having a heart failure, post-ischemic heart disease. Again, the patient that might have angina or equivalent with no obstructive coronary artery disease, and the growing more and more group of patients that are totally asymptomatic, but during a checkup, an ECG, a treadmill test, a stress echo, or other investigations, we find some signs of ischemia or some signs of ischemic heart disease, and we should consider these people as also part of the chronic coronary syndrome. So, of course, the role of the imaging is to... The role of imaging is basically to make the diagnosis, a precise diagnosis, but also to risk stratify the patients, high risk, low risk, intermediate risk, and also help with our treatment planning. So what should we go for? Should we go for ischemia or should we go for a plaque? Okay, this is a never-ending debate. A lot of people like more the ischemia because basically ischemia is the symptom of the obstruction and then the reality of having a symptom of the chest pain. And then some people will go for saying, no, chest pain is the manifestation of the presence of plaques. The more we have plaques, the more we have a higher risk of having vulnerable plaques and acute coronary syndrome. And this is what we want to treat. Of course, to have the whole picture, we need to have both. And today we have, as you can see, so many modalities eventually to check for our heart disease. Now, the key here is to know which investigation is best for our patient because they are not all the same. Some of them are purely anatomical mostly like CT, like invasive angiography, but adding the FFR to both these investigations or even CT perfusion sequences to CT, now they can have also some functional evaluation. The other investigation, whether it's CMR, stress echo, SPECT, or PET, these are investigations that are mostly functional for ischemia. So to help us, the latest guidelines, the SC prepared a stepwise approach for the management of these individuals. The first 3 steps we're going to cover. The last part is about treatment, so it's not part of this study. So how about the initial evaluation? This is what everyone does in the clinic. The patient comes. We have to have a good history, symptoms, physical examination, resting ECG, X-rays, so the normal investigation that we do for all our patients. And here there are 3 categories of conclusions. The first conclusion, we found out that the pain is not of cardiac origin. Maybe it's musculoskeletal. So we're done. This is a patient that ends here. The other one is, no, we actually realized that these symptoms are actually more acute. They are quite unstable, and the patient will go to the path of maybe acute coronary syndrome or more acute care. Or the third case scenario where actually we still don't have a diagnosis, the heart is still possible as a reason of this chest pain. And then here we go for further evaluation. And here I think we have some new insight from the guidelines. And one of them is having as a class 1A using the risk factor weight clinical likelihood model. So we need to use this model to classify the patient. What is the pre-test probability? What is the likelihood of having coronary artery disease? And based on that, basically, we will decide which best technique we should use for the patient. But also use additional clinical data like the echo, the ECG, to adjust this class, okay? And as you can see, as you're gonna see later, the coronary calcium score also to adjust this class. So for the patients that are at very low clinical likelihood, actually today as a class 2, we can consider deferring further testing. We can stop there, of course, is at the discretion of the treating physician, but we can say he's very low risk, well, let's stop. Also the patients with very severe comorbidity, low quality of life, we can again stop here and not treat. However, for all the rest, we need to confirm the diagnosis, and this is where actually it's important to know what to ask for. Why today this risk factor weight clinical likelihood model that the ESC stresses about and it put it as a class 1 indication to be used is important because actually if we go back to these calculators, the risk calculators that were used by the ACC-AHA and the one used during the 2019 guidelines, they actually overestimate significantly the probability of obstructive coronary artery disease. And this new calculator actually is much more accurate in terms of saying what's the likelihood, is it really very low risk, or more. And the use of this new one will reduce the number of patients that were considered moderate or with low risk to very low risk, and for these patients, we can just defer the treatment and not continue and do unnecessary investigation. So to give an example, because I think it's important to spend a minute here, even though it's a little bit outside of my talk, but we need to have points based on the points symptom score, 0 to 3 points. Shortness of breath on exertion gets 2 points, and then depending on the chest pain and how typical it is, we can get between 0 and 3 points. And then based on the gender and the age of each patient, the number of risk factors, we have 5 risk factors, including the family history this time, and then the symptom score, we can calculate what is the pre-test probability. It's very easy. For example, a woman of 65-year-old who has goes into this group, woman, 65-year-old. If she has, for example, 2 risk factors, the pretest probability with the score of chest pain 2 or 3, the pretest probability is 6%. 6% is low risk. So this is very easy actually, but quite important. Also, but this is not the only thing. We need to adjust this pretest probability according to the other investigations that we've done: resting ECG, treadmill test, echo, and a calcium score. And calcium score can help us, especially if it's 0, to reduce the number of further evaluation by reducing the category of the patient, for example, from low risk to very low risk, and then deferring the testing by doing the calcium score for practically all these patients. So this is the pyramid: very low score, very low risk. We know very low probability, defer testing. So how about the rest? So actually here, depending on the case, we have multiple class 1 indications. When it's mild or moderate risk, as you can see, between 5 and 50%, CTCA is a class 1A indication. Okay, so low and moderate CTCA, moderate and high risk, so 15 to 85%, it's perfusion imaging, so SPECT, PET, CMR, and stress echo. And then the invasive angiography, it's really for the very, very high clinical likelihood of ischemic heart disease, so more than 85%. Of course, after we have our first assumption. After we do the test, if the test is negative, the clinical likelihood is lower. If the test is positive, it's higher, and then it will help us to decide how to proceed further. So as we said before, for low risk, for moderate CTCA, moderate, we can both CTCA or functional, moderate or high functional, and then for very high risk, invasive angiography. All of these are class 1 indications. CTCA is a class 1A, the rest is a class 1B for functional imaging. Now, are all the tests for functional imaging the same? Actually, they're not. The latest guidelines stress on using more the PET-CT and the cardiac MRI as the preferred test when you want to go for perfusion studies. So now, to have quickly a few cases. This is a patient, 70-year-old lady, well-controlled hypertension. So 2 risk factors: hyperlipidemia, atypical chest pain. So the pretest probability, according to this guidelines, it's 7%. So this is low clinical pretest, low likelihood pretest probability. So what would you do in this case? Either a calcium score to try to see if it's 0, and then you would reduce the risk, or in the low risk, it's only CTCA basically. So in this case, we went directly to CTCA. Actually, the calcium score was more than 300. So CTCA was performed, and it showed actually a moderate coronary artery disease of proximal to mid RCA. So when you have moderate on CT, we need to do a functional study. So this functional study could be, of course, a perfusion MRI, PET, SPECT, etc. But also it could be actually based on the latest guidelines by the ACC and by the ESC as a class 2 indication, doing only the FFRCT. So this case, you can see the LAD is mild, you can see the right coronary is moderate, and this is the FFRCT, which is totally negative, 0.94 on all the vessels. Okay, so it's totally, there is no ischemia here and no need to further evaluate this patient. So this patient's only for medical treatment and risk factor management. Second case, 44-year-old gentleman, hyperlipidemia, asymptomatic, cardiology checkup because he's a pilot. So actually the treadmill showed minimal ST depression at peak exercise. Normally this patient, practically a lot of us might say nothing. The pretest probability, this is not the last one I corrected, but anyway, the pretest probability actually here is 2%. Only after adjustment with the treadmill result, we decided to do a calcium score. Now the calcium score actually came back as 86, which increased 90th percentile, so increased the risk of the patient, and CTCA was performed. And by looking at these images on the CTCA, you can see this very ugly plaque on the right coronary artery between segments 1 and 2, a plaque with spotty calcification, with positive remodeling, hypodense center, which also by CT is almost 70%. So at least moderate to severe plaque with high risk features on the CT. We did since we have the acquisition, we did an FFR CT here, and the FFR CT was almost significant, 0.82 directly after the plaque, and a little bit further on the vessel, it goes below 0.8. So anyway, this patient is a high-risk job because of being a pilot, so invasive angiography was done. As you can see here, how can we run this? Can you click, please, on the videos, 1, 2, 3? So this is the right coronary artery. Again, please. So this is the right coronary artery with the moderate to severe plaque, the ramus intermedius with intermediate plaque also. So of course, the right coronary artery was stented. And to finish my case is the last patient with a higher risk group. So a 67-year-old gentleman, hypertensive, hyperlipidemia, having chest pain on mild exertion. History of moderate mid-LAD stenosis, 40-50%, 7 years earlier on angiography. So of course, this is a higher risk patient where CTCA would be not very accurate because we already have a moderate plaque. Yeah, I'll finish up this case very shortly. So the likelihood is definitely more than moderate, more than 15%. So patient went for a stress MRI study, so a perfusion study. Please click on the videos. Please click on the videos. Okay, so you can see on the first one, a severe perfusion defect in the inferior inferolateral from base to apex. So it's either a dominant RCA or a dominant circumflex. In this case, it was a dominant circumflex, 99%. The MRI showed ischemia, viable territory. So invasive angiography was done with stenting. Well, with this, I'm going to finish the study. Thank you for your listening.
Thanks, Dr. Rami, for clear-cut presentation with elucidation with 3 important cases.
Thank you.
Yeah, with the lack of time, we can allow 1 question from the audience, if any. Anybody would like? Yeah, please go ahead.
Are high. Would you still put him on fibrates or not?
Yeah, current guidelines are very clear. If patient is already established atherosclerotic cardiovascular disease or diabetes or with additional risk factor,
Correct.
and if with the high dose of statin still the TG is high, you have to add the EPA, not the fibrates.
Right. And if with EPA still triglycerides are high,
You accept it.
you accept it.
Yeah.
The reason being with the fibrates, we don't have any clear-cut evidence of reducing MACE. That's the basic point. We are using fibrates only when the TG is beyond 500 to reduce the risk of pancreatitis. And EPA has got evidence, and that's why after statin we use EPA.
Like to present a plaque to.
So with this, we close the session, and we have got very good lectures. So I would like to thank all the speakers, moderators, and of course, audience. Thank you.
Dr. Rupesh, just one. Just hand over the flag to Dr. Mishra. Can I have a photo together of the party? Thank you all the speakers and moderators of the last session, and now we proceed for the next session. So the next session is on all women cardiologists. The session is dedicated to women cardiologists here, women cardiologists on the go. The session director is Dr. Peter. And out of other chairpersons, only Dr. Fatima is available. Other two have excused. So Dr. Peter and Dr. Fatima, please take the dais and start the process. Thank you.
Thank you very much. I have been involved in the Go Red American Heart Association effort for about 15 years and tried to get educated in this era of being aware of women's cardiovascular disease, which is #1 cause of death for sure. There's lots of different etiologic processes. Sometimes preeclampsia in pregnancy can be a risk factor. Endometriosis can be a risk factor. And often the symptoms and presentation of women can be very different. And I think the biggest issue, and I'd love, since I'm the only guy, I'd love to get your opinion here, but we need to have more awareness of this gap between men and women. In the 70s, it was basically all taught that it's men with cardiovascular disease. We've gotten better, but still the trials have not included a lot of the women's health in it. So I look forward to this program because it's really an important issue worldwide. You want to say something?
Thank you, everybody. Good afternoon for being here, dear audience and esteemed colleagues. And thank you, Professor Peter, for being here all the way from United States. As you said, subjects related to women cardiology and women health in general are very compelling. And as you mentioned, endometriosis or preeclampsia, polycystic ovarian disease, which is part of cardiometabolic disease, they are all risk factors for coronary artery disease. So this is session 7 with women cardiologists on the go. And I would like to ask Dr. Leila Al-Marzouqi, consultant cardiologist from King's College Hospital, to talk, to give the first presentation of this session about precision medicine in cardiovascular disease, a new era of personalized care. Dr. Leila, please.
Thank you very much, Dr. Fatma. Thank you very much, Professor Peter. Assalamu alaikum and good afternoon, ladies and gentlemen. Thank you very much, Dr. Mittal, for invitation to be one of the speakers in this successful conference. When Dr. Mittal asked me to choose the topic, I said, let's do something which is different and something which will take us into future, at least for this region for this region. So maybe in other places, precision medicine is already being implemented, but I think we still have got so much way to go, and the journey is still at the beginning. Let me see. Which one?
Green one.
Okay. Okay. All right. Okay. Thank you. We're actually living in a world that we say one size fit all, and we tend, unfortunately, to paint all our patients with one brush. When I was preparing for the talk, my daughter said, "What's the topic for your presentation?" I said, "Precision medicine." And she went, "Wow, is our medicine not precise?" That really was an eye-opening thing from my daughter. So precision medicine, I'm sure a lot of you have heard about it. And in this lecture, so I don't have enough time to go through all of it, but just at a glance, I would like just to talk about this topic. So medicine really has evolved from being in intuitive medicine in 1950s and 1980s, where we really understand the symptoms mainly, and we used to treat the symptoms without knowing much about the disease, and we give the medicine to the patient, and it really worked. Then we moved to evidence-based medicine, where randomized controlled trials came in, and if we wanted to check the medication, whether it works or not. And then we say, yes, after doing the randomized controlled trial, this medicine is good, but it worked on some people and it didn't work on other people, unfortunately. So that's why where precision medicine came. So it's personalized medicine or precision medicine. So some people, they say personalized medicine is kind of like unique medicine or unique treatment to that specific patient. But precision medicine is usually, it's more kind of like a broad thing, and it uses a lot of information where it looks into the gene of the patient, it looks into the protein and the biomarker, and it uses some of the AI, like our colleague the previous session, they explained about it, and it goes up to the extent that it looks like the microbacterial, for example, the microbacterial, which the microbes which are in my body, a difference from a lot of audiences here. So precision medicine looks at all of these aspects of each patient, so and give us a vast data and information about patient, and it leads us to do a correct and right diagnosis and the right treatment at the right time, and individualize treatment for a patient. So the traditional medicine versus precision medicine in this table. So the traditional medicine, we use the standard guideline and clinical symptoms, but in precision medicine, we look at the gene, as I've mentioned in my previous slide, and on the other data that I've mentioned in my previous slide. And then the treatment in the traditional medicine, one size fits all, but the precision medicine, we are very selective in the drug that we use based on the information that we get from the gene and from the proteins that each patient has, etc. And the effectiveness of precision medicine, of course, is much better than the traditional medicine, because it leads to more targeted treatment and less side effects. And the monitoring, of course, is 24 hours, as opposed just doing 24-hour blood pressure monitor, and we judge the patient accordingly. And then the treatment and the prevention, of course, what we tell the patient is a lifestyle advice or a medication, but the precision medicine, we get a tailored recommendation for the patient. So allow me just to take you, for sake of time, for some example in precision medicine in cardiology. So important topics I've chosen, 3 topics that are really close to my heart: hypertension, heart failure, and hyperlipidemia. So if a patient comes in with hypertension, is it fair to tell every patient in your clinic, please don't take salt? Is it fair for every patient who comes with hyperlipidemia to your clinic to say, let's start statin, and this is the dose, and then we tailor the dose until the LDL or until the blood pressure is within the guideline that we know? Is that the way to go forward? Unfortunately, it is not, because there's so much drawback of this, because some patients do not respond well, some patients develop side effect, and some patients, they need a higher dose of medication, and we as a doctor, we just increase the medication until the blood pressure is within in the systolic within in 120s. Is this the future though? Unfortunately not, because the role of precision medicine, it takes the genetic factor into consideration and tailor treatment accordingly. So some people with salt-sensitive hypertension may benefit more from diuretics, for example, and those with certain enzyme variation may respond differently to ACE or ARB. And then the continuous monitoring with the AI, with the Apple Watch, or all the different ways of monitoring is the other way that help us to be more precise. And there's so many reviews in the literatures about the precision medicine in hypertension. And we all know, for example, the calcium channel blocker, we should give it to young people, it works better. And then the obese people, beta blocker, they say it's better than non-obese people. And then, as we know, the hypertension is multifactorial disease. So that's why we have to take into account the lifestyle as well of the patient and their gene, and whether what they eat healthy or whether they smoke or not, etc. So the advantage is the right drug for the first time and avoid side effect and by predicting poor responder. And then familiar hyperlipidemia is the same. If somebody comes with hyperlipidemia, we prescribe statin and adjust the dose like the way we do for hypertension. But we don't account for a lot of other factors like the genetic differences, and some patient may not respond or may develop a side effect from the statin itself. So the precision medicine, we go into the genes, and then according to what information we gather from the patient, we can start more aggressive treatment and consider non-statin medication and do the family screening as well to lead to the targeted therapy and reduce trial and the error prescribing medicine. So these are the ways that traditional precision medicine differs in the treatment of hyperlipidemia. And we all heard about patients who are Plavix or clopidogrel resistant. And so these patients, especially for our colleague interventionists, cardiologists, they should consider this. So, and if patient is resistant to clopidogrel, to consider other medication in order to prevent the in-stent thrombosis. Heart failure and precision medicine is another area that I would like just to go through. And then if on the, here, if you can see that I've divided it based on these three categories, and according to that, we should select the way that we treat patient for heart failure. For example, if we go to the first the proteins, a different protein for different patient, and then the spironolactone, and how would they respond to these to this medicine as opposed to the other medication, and then the CA125 is the surrogate of fluid overload. And I'm just looking at the time there, but unfortunately the precision medicine has got a lot of limitation. Of course, cost is one of the main thing, and it's not accessible everywhere. And then a lot of data that comes from precision medicine, including the genes and stuff, it's come from countries like Europe and the state. Maybe we cannot implement it in other areas of the world. So we have to have definite information about our patient, and of course, if we want to practice precision medicine, then we need to collect a lot of data about our patient, which could then the problem of data privacy and the ethic comes in. And then the other thing is over-reliance on genetics may underemphasize the role of environmental, lifestyle, and social determination of health. So we are on the threshold of new era for treating patients with cardiovascular disease. We have to go beyond one model fits all, and we should really take into consideration the gene, the lifestyle, the proteins, the microbes in the body, and they are all important part of the puzzle. And we should not only treat the disease, we should have a better understanding of people of who carry the disease, which are the patient. And then we should go beyond of painting everyone with the same brush, and decide on start the use of precision medicine because it is the future, but not only the future, it's the responsibility of every doctor. So this is my last slide. So the main objective is prevent and therapeutic management of cardiovascular disease through a comprehensive approach that consider person genetic, lifestyle, and exposure to important factors that impact their cardiovascular health and disease phenotype. Thank you very much.
Thank you very much, Dr. Leila, for this interesting presentation. It's interesting to know that precise medicine will come in practice. I don't know when, but it's quite interesting to have a tailored-based strategy for every patient based on their biomarkers and genetics. And I'm sure we will get a lot of benefit from this. But I think with the current practice, we are still on evidence-based medicine, and this is what we are doing. Thank you.
Yeah, I was going to say that too, because we've been talking about precision medicine and the omics of a given disease process for a long time. And that slide that you had up, just one before the last, there's a ton of information that has to be integrated, whether it's metabolomics, proteomics, genomics, epigenomics, and test things over time, which I don't know, is it 5 years, 10 years, 20 years? And be able to feed that back to the peculiar training sets that might be applicable to the person that's in front of you today. When are we going to get there?
Okay, it's a very important question. I mean, this initiative was, this concept was brought up in the US in 2010, and President Obama had a very big campaign in 2015 about it. And today we are 2025, and still we've got a long way to go because of one of the things is the cost and not available to a lot of places. Of course, personally, I don't practice it still in my clinic, but we do part of it. Like we, as a cardiologist, we use, for example, the CHA2DS2-VASc score that has bled. But we are far away from, a mile away from precision medicine. But I'm sure the technology will speed up the use of this. For example, the AI is going to shorten the distance of us from using it on a daily basis, and for everyone that it's sitting in the clinic. But it still needs more, at least for this region, as I said.
Oh,
Thank you very much.
Thank you very much. It's wonderful. And I don't know what I'm doing here, but I'm going to have you come over here and we'll have a picture. How's that?
Thank you.
I would like to introduce Dr. Marta Asena. I'm sure most of you know her. She is consultant electrophysiologist from Rashid Hospital, and she will talk about ventricular ectopics, clinical significance, and management strategies. Thank you.
Laser. No. Okay. Oh no, I have the laser here. How to put the laser? This in the screen. Sorry. This one. No, it's okay. I will use. Okay. I would like to thank the organization for having me today. It's always a pleasure to be here. I'm going to talk about something very, very different, PVCs. How to do the next one. Yeah, it doesn't move. Ah, okay, it's moving. Yeah, okay. So we're going to talk about the diagnostic tools we have, how to decide the treatment strategy, and what are the strategies for the treatment that we have. Regarding the diagnostic tools, nothing fancy, just basic things that we all have in our clinics. A 12-lead ECG to localize the PVC, to have the morphology information. A Holter for calculation of the burden. echocardiogram to rule out any cardiomyopathy and to check on the ejection fraction. And an MRI will be optional. If you have outflow tract PVCs and normal echo, the MRI is not mandatory. But if the PVCs are coming more from the free wall, or the echocardiogram cannot rule out structural heart disease, then it will be necessary. This is an example of a useless ECG because, as you can see, is missing the PVCs in the precordial, in the right precordial lead. So please, when you have a case of PVCs, make sure that the PVCs are in all the 12 leads to have the morphological information. Regarding the holder must be a descriptive job. It's not enough to say in the report PVCs and 10% of burden. Describe if they are monomorphic. Describe if they are polymorphic. If they are monomorphic, is there a predominant? If they are polymorphic, sorry, is there a predominant morphology? 2 morphologies, 3, whatever. Describe if they are happening more during the day or the night, because if it happens only at night, the mechanism is different, is triggered by bradycardia and vagal tone. Describe if there are single PVCs always, or there are runs of VTs and how long these runs are. And finally, print out all the events. This is the algorithm for the decision-making strategy for patients with no structural heart disease. This comes from the European guidelines published in 2022. If the patient is symptomatic and the morphology is RVOT morphology or fascicular PVCs, then the catheter ablation is indicated with a class 1 indication. And in second option, you have the medical treatment with beta blockers, calcium channel, or flecainide. If these morphologies are not, if the morphology is not RVOT or fascicular PVC, then first choice will be medical treatment with beta blockers or calcium channel blockers as class 1, and catheter ablation is indicated as class 2A. If the patient is asymptomatic, no symptoms, and less than 10% PVCs, then you can discharge the patient. Reassure the patient and discharge. If asymptomatic and PVCs between 10% and 20%, then as per the guidelines, do regular follow-up because even if the patient is asymptomatic, a high burden, more than 10%, it can cause LV-induced, a PVC-induced cardiomyopathy. So do regular follow-up with echo to check on the ejection fraction. If more than 20% PVCs, do follow up with echo, and catheter ablation is also indicated in this case with class 2B indication. All right. This is the algorithm with, in this case, with structural heart disease patients. Okay, sometimes it's not working. Yeah. If the patient has LV dysfunction and you can explain this LV dysfunction by the underlying heart disease, then you will have to treat the heart disease. And if you have PVCs with induced cardiomyopathy, then class 1 indication for catheter ablation. In the last case, patients in between with underlying heart disease and aggravated with LV dysfunction, aggravated with frequent PVCs, then catheter ablation is indicated with less evidence, class 2A. And amiodarone will be the drug if you decide medical treatment for any reason. Yeah. Okay, so for the medical treatment, as per the guidelines, we have in patients with no structural heart disease and outflow tract or fascicular morphologies, we have beta blockers or calcium channel blockers. But I have to say that in clinical practice, what I give the most is flecainide. It has class 2A indication and it gives better results. It reduces more the PVCs and with less side effects. In the patients with LV dysfunction, amiodarone will be the drug of choice. Regarding PVC ablation, from less challenging ablations to more challenging, the outflow tracts are the easiest, I would say. Something in between will be the non-outflow tracts with no structural heart disease. The papillary muscles are quite challenging. Why has disappeared? Okay. And the most challenging ablations are those with structural heart disease, like ischemic heart disease or hypertrophic cardiomyopathy and arrhythmogenic dysplasia. These are the most challenging cases, by far. RVOT PVC ablation has the highest success rate. It has been published, the success rate of this ablation is around 80% to 90%, and our numbers are not different, 83% success rate. Predictors of success for ablation are the presence of monomorphic PVCs, RVOT morphology, and high burden before ablation. Ideally, more than 10% gives you better results from your ablation because you can map more easily. You don't have to wait for the next PVC to come. You have the PVCs coming frequently. And predictors of failure of PVC ablation is more than one morphology, non-outflow tracts, intramurality, even RVOT PVCs can be intramural and can be challenging, epicardial locations, papillary muscles, structural heart disease, or an entity called multifocal ectopic Purkinje-related PVCs. These are polymorphic PVCs coming from the Purkinje system, and this is just not ablatable at all. And I would like to present two cases of ablation. These are PVCs coming from the LVOT. It's positive in V1 and inferior access, narrow QRS, so it's coming quite close to the septum. By mapping in the aorta, you can see this would be the valve. You can have the help of an intracardiac echo to see the structure of the valve and the coronary ostia. But very frequently, LVOT PVCs come from below the valve because there you have the transition between the muscle and the fibrotic tissue, and you can have more reentries here at this level. And this is one of the cases below the left cusp. Actually, this was a reentry. Yeah. This was a reentry with nice diastolic potentials and double signals here in the ablation catheter. This is what happens while burning or run of VT. So we are irritating the correct tissue with the same morphology of the PVC. And this is the ECG after the ablation. And last case is a case of sarcoidosis, a very young man, a 34-year-old man with presentation to the hospital with a cardiac arrest for ventricular fibrillation. We put an ICD in secondary prevention. Before the ICD, we did this MRI that has to move. Yeah. This MRI nicely shows this huge aneurysm in the posterobasal left ventricle. And in the follow-up, we saw that the patient had shocks, and we saw that these shocks were triggered by these PVCs, monomorphic PVCs triggering these runs. So in this case, drugs were failed, amiodarone failed to control these PVCs, so we had to do an ablation. This is the morphology of the PVCs, quite broad and in superior axis coming from the aneurysm itself. So as they were broad and the aneurysm was transmural, the fibrosis was transmural, I decided to do an epicardial puncture to have the three axes in the ablation: right ventricle, left ventricle, and epicardium. And this is the image of the puncture with the contrast. This is the epicardium, and here is my needle. And here you have the wire surrounding the heart. In the end, I didn't have to use the epicardial access because the origin of these PVCs was endocardial. I could ablate first from the RV in the septum, and then it didn't work. PVCs were still there. And from the LV, doing like a sandwiching this area, finally the PVCs disappeared. Last slide. Okay. So as conclusion for the talk, a good diagnostic approach is crucial for a good therapeutic decision. Treatment of PVCs is recommended when symptomatic, when the patient is symptomatic or the burden is more than 10%. A burden of more than 20% is more likely to cause induced cardiomyopathy in the follow-up, although cases have been described with more than 10% as well. PVC ablation from the outflow tract has excellent success rates in the acute and the long term, avoiding long-term medications and side effects. And other locations outside the outflow tracts can be challenging, but possible with the use of advanced techniques like eyes, epicardial puncture, etc. Thank you very much.
You've got my curiosity going. So I got to ask one quick question, and that is,
Tell me.
in the coronaries, the difference sometimes between men and women is women tend to have more dissections, more spasm. They even have a broken heart syndrome they talk about. What about VT? I mean, in your tour from ablation to amiodarone with flecainide in between, what's just 30 seconds?
Regarding dissection of the aorta, when you go through the aorta?
No. That's the coronary division. I want to know what sort of division between men and women happens in your sport here, ventricular ectopy.
Basically, to be honest, I don't see any difference. During the ablation, I think the risk is the same.
The risk of ablation is the same, but what's the incidence, the prevalence that come into your practice? What's the ratio?
Well, PVCs are more frequent in men.
Yeah.
For outflow tract and for free walls also, because men have more ischemic heart disease,
Right.
so they have more ventricular tachycardias.
That's what I thought, but I wanted to ask the expert. Thank you very much.
You're welcome. Thank you.
Okay. Taking a picture here.
Oh, yes.
With the plaque. Sorry. Thank you very much.
So we will move to the third speaker of this session, Dr. Yogeswari, specialist cardiologist from Medical Royal Hospital. She will talk about coronary heart disease in women, a red alert. Please, Dr. Yogeswari.
Thank you. Good afternoon. And I feel very honored today, and I would like to extend my gratitude and thanks to Dr. Brajesh Mittal for giving this wonderful opportunity to discuss on a very critical but often an overlooked issue. So the scope of our discussion for today would be, it's a topic in itself wherein you have separate conferences being conducted, but I'll try to do as much justice as possible. So initially, we'll go through the burden of the disease, the unique risk factors pertaining to women. Estrogen, is it still a boon for us? Ischemic heart disease in women with special address to special populations, and multimodality imaging, and also how we are going to mitigate the risk so that we can reduce the risk of cardiovascular disease in women. All right, so by this time, I'm sure everybody must be aware that cardiovascular disease is the #1 killer, claiming more lives more than all forms of cancers put together. And it claims almost 35, the cardiovascular disease accounts for almost 35% of all deaths in women. That is around 1 in every 5 female deaths. Now, among the cardiovascular diseases, ischemic heart disease tops as the leading cause of cardiovascular mortality among women worldwide. And as much as I say that coronary heart disease is a red alert, I also feel a little bit more reassured because 80% of it is very much preventable. And there was this nurses' health study which was conducted over a period of 14 years wherein women were enrolled. And at the time of the study, they did not have any risk factors for cardiovascular diseases. And then those who adhered to a low-risk lifestyle clearly had 80% reduction in the cardiovascular events. So that shows how powerful lifestyle interventions can be. So, so as much, if you had seen in the previous, yeah. So if you see in the,
Maybe it needs a new battery. Next button, yeah. Smaller one. That'll go back.
okay. So that's the closest that we can get to getting the statistics of cardiovascular disease with respect to the prevalence, the risk factors, and the mortality and morbidity. And that was obtained from the global burden disease statistics. And you can see in here that the highest prevalence is seen in MENA region, which includes Middle East and North African regions. And that's really scary because it's only going to keep increasing. So the top 3 causes of cardiovascular disease prevalence in women include ischemic heart disease, peripheral heart disease, and stroke. But if you consider the cardiovascular deaths or the mortality, ischemic heart disease followed by stroke and hypertensive heart disease take the top 3 positions. And initially, after a... Okay. So after a lot of advancements made in the lot of guidelines which came and then advancements made in the treatment of ACS, so there's a significant decline in the mortality, cardiovascular disease mortality. But then after 2010, somewhere there was a stagnancy in the decline in the mortality, and that definitely calls for an imminent action, and we need to understand why it's actually stagnant and there is no further decline in the mortality of cardiovascular diseases, especially in women. Yeah. So coming to the risk factors of cardiovascular diseases in women, now we all know that there are this traditional risk factors, the well-established traditional risk factors. So you have hypertension, obesity, diabetes, dyslipidemia, unhealthy diet, smoking, sedentary lifestyle. But then there are also these unique risk factors pertaining to women, wherein you have the sex-specific risk factors and the under-recognized risk factors. And for some reason, these are called as enhanced risk factors, and still they have not been able to be placed in any of the guidelines so far. And clearly, they add to the risk of cardiovascular disease in women significantly. So I will be going through all of these risk factors in the next slide briefly. So even if you take the traditional risk factors compared to men and women, for example, you have a diabetic man and a diabetic woman, clearly the woman has significantly increased risk of developing cardiovascular disease as compared to men, even if they belong to a premenopausal age group. So even for the well-established risk factors, if it is present in women, the cardiovascular disease burden is clearly high. So coming to obesity, we all know that obesity is more prevalent in women by at least 50%, and thereby is more, it has a more impact on the cardiovascular disease burden. And then smoking, if you see, overall, the smoking prevalence is less in women, but in young women these days, we see a lot of people who smoke, who vape, and clearly the impact of smoking on cardiovascular disease burden is very high as compared to men. Now, hypertension is the most important factor as far as women is concerned, and most of the women are tend to be poorly controlled, and that also increases the cardiovascular risk. Now, sedentary lifestyle, stress coming under the psychosocial risk factors is one of the underestimated risk factors as far as women is concerned. And diabetes, as I already mentioned, and there is something called as the APO, adverse pregnancy outcomes, which means high-risk pregnancies complicated by gestational diabetes, and then PIH, gestational hypertension, preeclampsia, those who have PCOS, those who have preterm deliveries, those who have low birth weight. So all of these are at increased risk for developing cardiovascular disease in the near future. And it's very important that we follow up these patients. And most of the times, once they deliver the babies, it is hard for any, even for the mother, they are so much overwhelmed with the joy of welcoming a new one, and therefore they completely forget about their health. They don't really prioritize their health. So it's very important that these women are followed up in high-risk obstetric clinics and cardio-obstetric clinics so that we can pick them up very early. And coming to mental health, clearly we know that women are more likely to experience depression, anxiety, abuse, and trauma-related disorders, eating disorders, and these all have been implicated to increase the risk of cardiovascular disease in women. The chronic kidney disease and cancer, especially breast cancer, when women receive chemotherapeutic drugs and radiation, so clearly they also pose an increased risk of cardiovascular disease. And autoimmune disorders, which disproportionately seem to affect women compared to men, also are implicated in increasing the risk of cardiovascular disease. And all of them have inflammation as a baseline. And we all know that atherogenesis carries a lot of inflammation, and it clearly increases the cardiovascular disease. So apart from this, we had the polycystic ovarian syndrome, wherein it is associated with, it is a metabolic disease. So you have increased insulin resistance, you have obesity, you have diabetes. So all those things, again, is going to put the patient at an increased risk. So estrogen, is it still a boon? No, estrogen clearly has robust cardioprotective benefits. So as you can see here, it induces angiogenesis, vasodilatation, it inhibits apoptosis, it decreases the pro-inflammatory markers, it decreases the procoagulant factors, it also reduces the reactive oxygen species, and all of this clearly is going to help in maintaining the endothelial function and the microvascular function. So obviously when you hit menopause, and all the more reason when you hit menopause early, your cardiovascular disease risk definitely gets heightened. And when the estrogen is no more there in your body, definitely the insulin resistance goes up, you land up with hyperglycemia, there is endothelial dysfunction, there is increase in visceral fat. So all of this contribute to increased heightened risk of cardiovascular disease. So now coming to ischemic heart disease. So under ischemic heart disease, we have the obstructive and the non-obstructive CAD in women. So when it comes to obstructive CAD, clearly 7 to 10 years later is what women present as compared to men. And the prognosis is generally very bad. For example, if you take a woman, she starts developing chest pain or palpitation. Most of the times she tries to do some home remedies, and then she literally waits for somebody to come and pick her up. Even if she decides to go to the hospital, she really wants to make sure that her kids are kept safe when she goes to the hospital. So that is a mentality of women anywhere all over the world. So clearly there is a significant delay in the presentation of women. And first of all, they themselves are not aware of the risk of heart disease that they can have. So there is a clear lack of awareness among women that they also will be prone to getting heart diseases. So this concept of golden hour is never going to happen for women because there is a clear, prolonged, untreated ischemic time that is prevalent in all the women because most of them reach the hospital very, very late. And the concept of golden hour gets thrashed when they are exposed to a prolonged ischemic time. So as Dr. Peter was earlier mentioning, we probably have to make use of AI wearables to see if we can reduce the home to balloon time in the first place. So after having reached the hospital also, studies have shown that they are less likely to receive guideline-directed medical therapy. And even if they receive so, they are less likely to receive the GDMT and a follow-up. You see most of them with their medications. So they have a higher 30-day mortality compared to men, and for all these reasons. And as I told you, even whether the woman is premenopausal or whether the patient is postmenopausal, if they have all these traditional risk factors, it puts them at a much higher risk as compared to men. So coming to the non-obstructive coronary artery disease, before that, in ACS, it was originally and traditionally misconceived as a man's disease. And despite advances in treatment, as I told you, for all of these reasons, there has been poorer outcomes when women present with ACS. And all the more, they tend to have smaller vessels, they tend to have hypertrophied heart, they tend to have hyperemic blood flows. So there is also this role of estrogens. So all of these, supposing they tend to have the smaller blood vessels, so they tend to have repeat ACS events. They tend to have increased risk of restenosis, and they tend to have increased incidence of heart failure following ACS events. So these are all more peculiar to women primarily because of all these issues. So, and in the non-obstructive CAD, we have INOCA, MINOCA, and the ANOCA. So I will just quickly move on to the next slide, wherein it will tell us the difference between all of the three. So here we have the ANOCA, wherein patient has classical anginal symptoms, but there's no documented evidence of ischemia or biomarkers are negative. And INOCA, wherein there is inducible ischemia, there is classical anginal symptoms, but the biomarkers are negative. In MINOCA, patients have classical biomarker being positive, they present with myocardial infarction, and they have documented evidence of ischemia, but when you do the coronary evaluation, they all turn out to be normal. So it does not mean that they don't have increased risk of MACE. In fact, they have been told to have higher risk of MACE, and these are all the various pathophysiological mechanisms underlying that. So, yeah, just a couple of slides on SCAD. Actually, the spontaneous coronary artery dissection is more common in young women, and hormonal influences, fibromuscular dysplasia, connective tissue disorders are more commonly implicated. Less than 50 years of age, and in young women, this is the most common cause of myocardial infarction. Most often, we resort to conservative management in these patients. Unless they present with hemodynamic instability or in LV dysfunction, then we take the patients for PCI or for CABG. So cardiovascular imaging was dealt with in detail by Dr. Remy, so I'm not going to go into it. So we have a highly specialized cardio-obstetric clinic in our hospital wherein all of these high-risk pregnancies go through our clinic so that they are eventually also followed once they deliver their babies. So also a couple of slides on the menopausal hormonal therapy. As of now, there is no indication for primary as well as secondary prevention of cardiovascular diseases. Okay, but again, it has to be individualized depending upon how young the patient is, how severe the symptoms are, and we also need to assess their cardiovascular risk before initiating the patients on medication. So I think women are anatomically, physically, and biologically very much different from men. So it's not right for us to follow the guidelines wherein all these trials most often involved only men. So as per the Lancet Commission data, women are under-recognized, under-diagnosed, and under-treated. So all this can be managed only if women have more representation in clinical trials. And so I think even in this conference, we have very less representation of women. So I hope this gets better in the future.
You had some challenges with your pointer there.
Yeah.
So,
I'm sorry.
no, it's very important. And I think awareness on both sides is really important for this gap, this gender gap that we see. So congratulations. Thank you
Thank
very
you.
much for your presentation.
We will move to the last speaker of this session, Dr. Miradola, interventional cardiologist, Medcare Hospital, Dubai, and she will talk about acute coronary syndrome, new guidelines 2025.
Very good evening, dear colleagues and friends. And I want to first thank Dr. Mittal for arranging such a beautiful conglomerate of all the topics and covering almost everything from top to toe in cardiology. So I will just be talking in brief because I know we are running out of time. So my topic is 2025 new ACS guidelines for management of acute coronary syndrome as published by ACC, AHA and SKY societies. So as we all know, there have been in the past many guidelines and we have been following, and there are legacy trials which we have practiced in our daily lives and daily practices, and we have had good outcomes in our patients. But this guideline is basically sorry. So this I think I'm hitting twice, huh? Yeah, okay. So these guideline are updates from basically 5 previous guidelines. So 2013 ACC-AHA for the management of STEMI, 2014 for management with NSTEMI, 2015 focused update on primary PCI for patients with STEMI, and 2016 focused update on duration of DAPT with coronary artery disease, and 2021 guideline for coronary artery vascularization. So basically, this guideline is updated on these previous trials. So I would cut short on this slide. It just shows basically that the immediate transfer of the patient from home to first medical contact to the PCI capable cath lab. Within 10 minutes of first medical contact, you do the serial ECGs and try to transfer the patient as soon as possible to the PCI capable cath lab, because each 30-minute delay is associated with almost 7.5% relative risk of 1-year death. Now, I would mainly talk on the top take-home messages. So one by one, I'll take you through and try to collaborate with the trials associated with making them top take-home messages. So we all know DAPT is recommended for the patients with ACS, and ticagrelor or prasugrel is recommended in preference to clopidogrel. So this new update is mainly about considering more about procedural care, changing some antithrombotic strategies, and more on the statin for lipid management. It is also important to know that it is harmful if we give prasugrel in the cases of stroke or transient ischemic attacks. Now, the second thing is duration of DAPT. So DAPT we have been using for many years now. It has been stated that DAPT for 12 months is a default strategy, as you can see in the first column. And as you can see in the first column, it is a default strategy for 12 months. And if you have to do bleeding reduction strategies for patients who are either old or some other reason, then we give DAPT for about 1 to 3 months. And then if they've tolerated ticagrelor, then continue ticagrelor for the rest of the year. And ticagrelor monotherapy is preferred over other P2Y12 inhibitors. Then if the patient requires oral anticoagulation, we discontinue aspirin 1 to 4 weeks post PCI and then continue with single antiplatelet with oral anticoagulant. So now since the bleeding risk might be more, we prefer to de-escalate to clopidogrel. Then these are class 1 indication for all these 3 different categories. Now, if the bleeding risk is even higher, then class 2 indication is for continuing DAPT for about a month and followed by either DAPT with clopidogrel as a P2Y12 inhibitor or a single antiplatelet therapy with either aspirin or a P2Y12 inhibitor. Now, the little change I wanted to just compare the two and let you know that in the previous guidelines, all of these which I mentioned, there was a class 2A indication in patients with NSTMI treated with DAPT, and it was they gave it a recommendation of 2A for ability to use ticagrelor in preference to the to then existing clopidogrel, a more preferred drug. Whereas now in this guideline, it is class 1 indication for using prasugrel or ticagrelor to reduce MACE and stent thrombosis. And the same thing is bumped up to STEMI managed with PCI. It should be administered to reduce MACE and stent thrombosis. Now, also in if in case of transition, we use ticagrelor compared to other P2Y12 inhibitors. So ticagrelor is a choice of medicine for a single platelet antithrombotic. Now, next top take-home message is how to decide in NSTEMIs whether we should immediately go for invasive strategy or selective invasive strategy. So those with high-risk patients, I would rather tell you in this slide, which shows that high-risk patients and very high-risk patients which are having cardiogenic shock, symptoms of heart failure or valvular regurgitation, refractory angina, or there is hemodynamic or electrical instability, they should go for immediate invasive strategy, class 1 indication as far as possible within 2 hours. Those with high risk NSTEMI or intermediate NSTEMI, they are also recommended to have, it is recommended class 1 recommendation to have a routine invasive strategy. In the high risk, you are having steeply rising troponin values, ongoing dynamic STT changes, whereas in intermediate, there is no typical ischemic symptom ongoing. The gray score is less than 140, between 109 to 140, and there is declining troponin value. So here, the preference would be to do angiography before the discharge, preferably within 72 hours. Now, low risk are the cases where, again, a class 1 indication for routine invasive or selective, depending on case to case, and preferable to do some other modalities of ischemic assessment, either by CTA or other, and then deciding as per the result as to invasive or conservative. Now, a word on intravenous P2Y12 inhibition. So it has been given 2B indication for all those cases of ACS undergoing PCI who have actually not received P2Y12 inhibitor, either because of vomiting or they have a nasogastric tube or they are comatose. Comatose is another category, which comatose patient we are thinking of taking for PCI and acute coronary syndrome. And those patients who are requiring CABG or other surgery early after PCI. So we cannot discontinue for a longer time because the time for platelet deactivation is longer in the oral and faster in Cangrel. By the way, Cangrel is now available in UAE, so I wanted to talk on this slide specifically. So in these subgroup of patients, we should be able to, we should consider using Cangrelor. And as suggested by some trials, Champion has had 2-3 set of trials. So, and this I already told, this is the physiological effects and pharmacodynamic aspect of it. Now, another thing, statin therapy has also been given too much importance in this particular trial, wherein we have known from all the previous trials, Improve It or Odyssey or Fourier trials, that they have high intensity statin therapy or associated with adjunct to statin therapy in the form of either PCSK9 inhibitors or inclisiran and evalucumab or alirocumab kind of drugs and bempedoic acid. So adding these medicines reduces MACE and death. So these are important therapies to be added. And as you can see in the recommendation, what they have added is those patients who are already on maximally tolerated statin and their levels are, these are the baseline levels when they come with ACS. So when the LDLC is more than 70 gram %, adding this is a class 1 indication, all the group of drugs I just mentioned. And all those who are having LDLC between 55 to 70 milligram %, they are also, they have preferred to add, but it is reasonable indication, class 2A they have given. Now, this is a little comparison of the two. There were no previous guidelines, no recommendations about this concurrent initiation of ezetimibe, but now it has been given class 2B. And even for addition of same non-statin lipid-lowering therapy in those who are statin intolerant, they have been given class 1A recommendation. So it's a strong recommendation, those who are statin intolerant, to add all these, because then they will not have any means to reduce the LDL level. Then in patients who are already maximally tolerated statin with the levels between 50 to 70, adding is reasonable to reduce the risk of MACE. So keeping the levels less than 55 is the aim. Now, two procedural strategies have been added in this particular 2025 treatment guidelines, that radial procedures are better than femoral procedures to reduce the vascular complications. And they've given class 1 indication because it reduces bleeding, vascular complications, and even death. And also, under all those undergoing PCI and left main or complex lesions, intracoronary imaging with IVUS or OCT is recommended for procedural guidance to reduce the ischemic events. It is very important, if all these cases are having complex vascular anatomy, to know the extent of the length of the lesion, the extent of calcium, to see the well stent opposed and no malposition. It is important to do intracoronary imaging to know the details of the vessel. Now, this is telling the same thing. Also, the next one is whether you have to do in multi-vessel diseases a complete revascularization for infarct-related artery and the non-infarct-related artery at the same time. So there's class 1 indication for STEMI with multi-vessel disease after the PCI of infarct-related vessel. A significantly stenosed non-infarct-related artery deserves mention, and it should be done as per the recommendation to reduce the risk of death and MI and to improve the angina quality of life. So class 2A indication is given for those who are having complex multi-vessel disease, but elective CABG for significantly stenosed non-infarct-related is being considered. So this is class 2 indication. Class 2B is for STEMI with low complexity. So low complexity and high complexity would mean, high complexity means either left main disease or diabetics with LAD disease involvement or patients with reduced LV function. And so those are given class 2B indication. So this, at the time of PCI, they can be preferred over staged approach to reduce the risk of cardiovascular event. And those who are coming with cardiogenic shock, then we prefer to do only the infarct-related artery and not the PCI for the other vessels. So I'll go past 5. This is, I'll go past this.
Time is over, Doctor.
And the management, I think we'll skip this. I'll go to the urgent CABG in some patients. CABG in whom PCI is not feasible or there's a large area of myocardium at risk, emergency or CABG surgery can be effective to improve the clinical outcomes. Then this is in cardiogenic shock. We have already been told by Dr. Peter in detail about the use of MCS, the cardiac support device, and it has been seen, given class 2A indication in patients with STEMI and severe cardiogenic shock. So insertion of the microaxial intravascular pump is reasonable to reduce death. This study was done in small centers in Europe by the name of Danger Shock, wherein about 300 patients were enrolled, and they were the study showed reduced 180-day mortality in patients in whom the impeller device was used. But there were some catches to the study that there was underrepresentation of the woman, but definitely the study was good with a hazard ratio of about 0.74 for improvement of, for better the 180-day mortality reduction, but at the cost of complications of limb ischemia, kidney failure, and bleeding. So also there is class 1 indication. Okay, fine. So we will stop. Not a problem. Not a problem. So this was Danger Shock. And there were a few exceptions to the use of VA, ECMO, and IABP, but now they are also not recommended in routine cases. I think I'll end there.
Perfect. Thank you. Thank you very much. And I think we're going to delay the discussion section because it'll get me in a funny way if I start
Yeah, no problem.
But thank you very much for all the folks.
Yeah.
Okay.
Out of your ACS scanning presentation, what is the most important take-home point? What is
Should-
the best thing which has been done?
Intracoronary imaging and radial. Try to do radial intracoronary imaging. Also, which I missed in the last two slides, if the hemoglobin is low, less than 10, try to do IV infusion of iron in order to improve to more than 10. And of course, post-discharge, also use of statin, strict adherence to statin therapy. So do it 4 to 8 weeks after the discharge, because many times we transfer them to the community doctors or they go to GPs and they tend to reduce the statins thinking that everything is fine. So to educate them to have the good levels and
Thank you very much.
So get it back to Dr. Fadli.
I'd like to extend my heartfelt thanks to Dr. Brajesh for the successful meeting as usual and inviting me. Thank you so much, Doctor.
Thank you, Dr. Shikha, for conducting session so well. Thank you so much, and we move forward quickly to the next session, which is based on guidelines, and this is a session from CSI UAE chapter. So I call upon the chairpersons for this session. Dr. Sushim Sharma is our very well-renowned physician in the city and a very old member of CSI India. So please, we welcome Dr. Sushim as a session director and Dr. Praful, Dr. Sundar and Dr. Rupesh to join on the stage. I'm very extremely sorry, but we have to stick to the time and please stop at your designated time. This is the rule here for everybody, no exceptions. It was for everybody, for me also. Thank you so much.
As for the shortage of time, we'll just start the next session. May I request the speakers to just follow the timelines as indicated by Dr. Mittal. And the ESC 2024, so many guidelines have come. The first one is on hypertension. So may I call Dr. Jairam from Burjeel Hospital, Abu Dhabi to start.
Hi, good afternoon, and thank you for the invite, Dr. Mittal. And I realize that one of the best ways to prevent hypertension, especially in Brajesh's case, is to finish this on time. So, that's one additional form of treatment. I will go through these slides quickly just to highlight the differences between what we see now versus before. And I hope to finish on time. Question first that we need to answer is, why do we need new guidelines? We see them every year, right? The most important reason for this is there is still a large number of people who are untreated or have not achieved goal. Number two, most of these guidelines are actually quite confusing, and they, the whole point of a guideline is to make things simple, not to make things complicated. But my slides are anything but simple, so we'll try and simplify those slides. What has changed in these guidelines, right? Which is why it becomes more pertinent. I think first and foremost, they've sort of understood that blood pressure is not something that jumps from normal to abnormal. And it is a continuous process where there is an in-between area, which now they term elevated blood pressure, where in patients with a high cardiovascular risk or in patients with certain hypertension, mediated organ damage, they need to be treated despite their blood pressure traditionally being under the normal range. Also, they have highlighted the use of combination therapy early in treatment of hypertension to achieve goals. Most important, they have also touched upon resistant hypertension and some sort of treatment for the same. So how has it changed? If you look at the the European Society of Hypertension guideline, this was a nicely made slide. It talks about the master plan for hypertension. M for measure and accurately diagnose. A for assess the patient with a good physical examination, a good medical and past medical history. ST is for select the right therapy, and most important is ER is evaluate response in a timely manner. So what the ESC has said is that non-elevated, so they've just divided into three simple categories. One is non-elevated, which is any systolic and diastolic BP less than 120/70. Hypertension is if the blood pressure is above 140/90, and anywhere in between that is termed elevated blood pressure. Now, what is the treatment target for most patients? 90% of our patients, we'd expect the blood pressure to reach 120 to 129 in the systolic range and between 70 to 79 in the diastolic range, except if they are very old, very frail, have a limited life expectancy, or have symptomatic postural hypotension. Busy slide. What I'm trying to say here is that they put a lot of emphasis on not just blood pressure measurement in our offices. As you will realize, most of our patients have a high blood pressure there, but the judicious use of home BP monitoring and ambulatory BP monitoring. The advantage of an ambulatory BP monitor and the home BP monitor is obvious: masked hypertension, white coat hypertension, patients with marked variations in their blood pressure through the day, patients who have suspected postural or postprandial hypo or hypertension. All these can be picked up through, measuring your blood pressure through 24 hours. The ambulatory BP monitor uses 20 to 30-minute intervals, checks it even through the night. The home BP monitor, what's important is to educate them to take it in a relaxed manner, take more than 2 readings, and to take it for about a week or so to average out the readings. Like expected, I'll just go back. Office blood pressure should be less than 140/90. The home BP monitor, because it's in the awake state, should be less than 135/85, and the average of the ambulatory BP should be more than less than 130/80. Now, A is for assessing the patient. Judicious use of history, physical examination, and certain lab testings. Right? There were plenty of lab tests, plenty of other extended tests that were recommended by the European Society of Hypertension. What the European Society of Cardiology did is they tried to modify or minimize the requirement for all these. What they've certainly asked for is a judicious and a detailed history taking. Look for family history of hypertension in a younger age, cardiovascular, cerebrovascular disease. Look for sleep apnea, look for socioeconomic inflammatory diseases, presence of the same, look for any pregnancy related problems, and all this adds on. I'll show you a last slide, which is like a take home message that tells us how these can be important, especially in the people with elevated blood pressure. And that's where we are trying to target these people. People with a known blood pressure more than 140/90, anyways, we are going to treat. So we'll skip to the next slide. So here is where we look at people who have a high risk factor. People who are established high risk, proven coronary vascular, cerebrovascular disease, moderate to severe kidney disease, presence of diabetes, familial hypercholesterolemia, or the evidence of hypertension-mediated end organ damage. For people with elevated BP who don't have any of the above, they recommend the use of a score 2 or other scores based on their based on their age and whether they're diabetic. And if the score is again more than 10%, they are deemed high risk and treated as high risk individuals. The elevated BP will need to be treated. If they are within the 5 to 10% range for the score, then they would expect that you look for any evidence of either hypertension-mediated end organ damage or non-traditional risk factors, which predominantly are like like the doctor before said, gestational diabetes, gestational hypertension, preterm babies, preeclampsia during pregnancy, socioeconomic factors, inflammatory diseases, HIV, etc. In terms of HMOD, 2-3 things we need to look at. Look at the fundus, look at the ECG, maybe get an echocardiogram done. Lot of emphasis on LV diastolic dysfunction as one of the hypertension-mediated end organ issues. Look for an ankle brachial index and look for microalbuminuria. This is pretty much the same thing. So again, in the physical examination, don't forget the ankle brachial index. Look for any carotid or other bruise and look for signs for secondary hypertension. One important thing that they have, always looked upon is to look for assessment of how fit the individual is, especially as they grow, older. Their cognizance goes down, and in these patients, maybe giving a little bit of leeway towards treating the blood pressure is an important facet. They have asked for inclusion of renin and aldosterone levels apart from all the other routine workup that is mostly done for these patients with hypertension to rule out aldosteronism. As if they are less than the age of 40, you look for secondary hypertension and its causes. so kidney ultrasound, etc. Therapy, like most of us do, if the blood pressure is more than 140/90, we give them up to a month with lifestyle changes, provided there is no evidence of end organ damage or the high risk features. If either of them are present, then we start treatment immediately. Treatment generally starts with a combination of 2 drugs. It might move on to 3 drugs. The only time when we will consider monotherapy is when the patient is extremely old or there is postural hypotension. Busy slide again, but basically what it's trying to say is that lifestyle interventions form the core or the basis of treatment of all patients with hypertension, ensure that the salt consumption is less. They have put more emphasis on potassium supplementation and incorporated enough exercise. So about 150 minutes of moderate to vigorous activities or 150 to 300 minutes of slow to moderate activity, apart from all other lifestyle changes. Pharmacology, like described by many of my colleagues today, start with a 2 or a 3 drug combination, pretty much an ACE inhibitor or an ARNI, along with a calcium channel blocker or a diuretic. Scale up quickly in 4 to 6 weeks by adding the third medicine. It is better to add low doses of more medicines rather than up titrate the singular medicines to its maximum doses. Certain conditions would require specific management. Things like atrial fibrillation, heart failure, previous MI might warrant a beta blocker to be added before any of these. They have also emphasized on the role of eplerenone in patients who are, who cannot tolerate spironolactone in pharmacology. So basically select your therapy, start treatment early, lifestyle changes start immediately, evidence of hypertension mediated end organ damage, you want to and or the high risk features or the score more than 10, you will want to start therapy immediately, preferably with the dual therapy. Only if the patient is slow, is old, cognizance is not great, severely debilitated, that's when you'd look at starting with monotherapy. What is your goal? You'd want to try within the first 4 to 6 weeks to optimize their blood pressures. That is, in most cases, to less than 120, to between 120 to 129 with the systolic and between 70 to 79 with the diastolic. Except if they are very old, very frail, or have limited life expectancy or have severe postural hypotension, in which case you go as low as possible. More important than this is first achieving goals and then maintaining them in the longer continuum and regular tests to make sure that their hypertension mediated changes in the organs don't get worse. Look for microalbuminuria, look for ECG changes, check the person's echocardiogram, fundus from time to time. So this is pretty much my last slide, and we'll go through this in a little bit of detail since I have a minute and a half. If it is proven hypertension, which is the red part below, there is no doubt. We start treatment, we give 2 or 3 medications and optimize treatment. I think the yellow spot in the middle is the one that's most important, which is elevated BP. So in that, you look for any high risk features. If the patient is very old or very frail, then you just start with lifestyle and screening, repetitive screening. If the patient is relatively young, if he has high risk features, established cerebro-cardiovascular disease, presence of moderate to severe CKD, diabetes, or familial hyperlipidemia, or if he has hypertension-mediated end organ damage. If he has none of these, again, you just serially follow him up. But if he has one of them, then you do the score criteria, and based on the score criteria, if he is in the low score, which is less than 5%, you just try lifestyle measures for some time and serially follow up. If he is in the moderate range, then you would look for assessing additional risk factor modifiers, which is the white screen on top, where you look for gestational diabetes, hypertension, preeclampsia, or poor socioeconomical conditions, severe stress, and depression. If these are present, you would need to start medicine. Of course, if the score is more than 10 in these patients, we start blood pressure treatment along with lifestyle measures to control his BP. I saved 7 seconds.
We'll have question and answers at the end of the session, please.
Thank you very much for the opportunity.
Next, we'll have Dr. Virendra Kumar, the cardiologist from Burjil Hospital.
will sum up some of the important key messages in the atrial fibrillation 2024 ESC guidelines. So good evening. It's almost everybody is tired of since morning, so I will not take much time. And it is very simple. It's just guidelines, which is what in 2024 they came out. So if you see it here in the past guideline, I pressed 2 times because of slow thing. It's okay. In past guideline, it was ABC, which has changed now to CARE. CARE is comorbidity and risk factor management, avoid stroke and thromboembolism. Yeah, avoid stroke and thromboembolism, reduce symptoms by rhythm control, and evaluate. Frequent evaluation is important. So what they have come out is patients comes with a lot of symptoms. What is more important for them to assess whether this patient has a high significant morbidity or mortality. So may have come shortness of breath, syncope, anxiety, chest pain. But if he has a recurrent hospitalization, it has an adverse outcome in atrial fibrillation. If he is frequently coming with stroke, thromboembolism, vascular or cognitive changes, that means this guy is the one who is of your target because he is carrying high mortality with atrial fibrillation. We know that this disease is going to be double in 50 years. So healthcare economic cost is also a huge thing. AF is centered about all these comorbid conditions. So if you look at the comorbid condition, depending on lipid profile, to chronic kidney disease, to physical inactivity, and all heart failure, coronary artery disease, vascular disease, all are causing adverse outcome in atrial fibrillation. So the guideline came out and they say in this group of the patient, we have to control and recommend that these patients should have a better control of heart failure, better control of SGLT2 and glucose control, diabetic control. If they have a high weight, bring it down to 20 to 25%. If they have a still possibility of bariatric surgery, recommend them for bariatric surgery 2B. If they have an obstructive sleep apnea, manage them. So all these clinical conditions is being recommended to manage more effectively. And this recommendation has come as a beginning and given a good starting that these patients should have a good control. Coming to a CHAD-VASc score. Now no more CHAD-VASc score, is CHAD-VA score. They removed the sex. And there was a lot of discussion why they are removing the sex, with the sex has a little more high risk. So the discussion has a long discussion to remove, not to remove, and in the guideline they have written that there is a lot of patients, they don't want to disclose their sex. So where you're going to put them? And this is a trend. Second thing they say, in the end, there was not much difference statistically. So it is removed now. Only 2 points have true score, which is one is the stroke, and if somebody who is above 75. Rest all have one score and the same as before. So this is some change in the latest 2024 guideline. And what is other recommendation? In other recommendation, if you have a classical score of 2, you are going for anticoagulation. If you have this is class 1. If you have a score 1, you are still going for anticoagulation and class 2A. So the only thing which is escaped is 0 score. If you have 0 score, okay, you don't need anticoagulation. Rest all AF need anticoagulation. Other thing is, irrespective of CHAD-VASc score, if you have a hypertrophic cardiomyopathy or cardiac amyloidosis, you are going for anticoagulation, class 1B. And another thing say, don't reduce the dose just by any notion, unless it is guideline decorated or guideline advised doc reduction of dose, otherwise class 3. adding any antiplatelet thinking, okay, this is high risk in for this additional. No, they say class 3. So go for the guideline, give anticoagulation. Another recommendation is they came out that by classification, you can revert them up to 1 year. Even patient has persistent atrial fibrillation. And he thinks that the rhythm control can reduce it up to 1 year, class 2A. Then they also says that if patients have a AF longer than 24 hours, and this longer than 24 hours, but you want to convert them as a rhythm because of the symptoms, then you have to anticoagulate them and transesophageal echo. Before we say up to 48 hours, okay, it is safe to revert. They say no, maximum up to 24 hours. Otherwise, do change it and, oh, okay, I think we gone up, back. Yes. Then another thing they suggested that when your patient is a high risk for probably developing after surgery atrial fibrillation, start amiodarone pre-surgery. This is as a class 1 recommendation. And if somebody has a probably umbilical stroke episode and say maybe this guy has a AF, unless it is documented, do not start anticoagulation class 3. So don't go for this. You have to have documentation to stress on your management. And this is a temporal pattern of atrial fibrillation, some classification, some changes, not much. Like first time diagnosed, everybody knows simple one, early diagnosed. Paroxysmal is up to 7 days. Anything person has AF, whether he revert spontaneously or reverted by your treatment, up to 7 days, it is paroxysmal. If we are beyond 7 days, it is persistent. Even when he goes to sinus, does not matter. If he is persisting, non-persisting, if he has continuously for this month, his diagnosis changed to persistent. But in persistent, you still have an attempt up to 1 year to revert them back to sinus. But in permanent, when you decided no more attempt to bring them back to sinus, labeled as permanent. So there's some little bit twisting of the word. Then another one is patients, when we diagnose initially, suppose patient comes and you did ECG, ECG shows AF. When he comes to you, he's in sinus. So what level you will go? It is only 30 seconds. So they say even with the 30 seconds, symptomatic, asymptomatic, it is clinical AF. Your diagnosis is patient has AF. So even if it is as small as this, then comes device detected atrial fibrillation, asymptomatic, Holter recording, is monitored by pacemaker or any device, and they diagnose, okay, he has a AF. What do you do with this? So guideline says, go case by case, seize the risk. If it is more than 5 minutes or 6 minutes, go for anticoagulation, class 2-1A. So this is another one. Even device detected AF has got high predictor value for clinical AF in future. AF burden, all of you know, we can calculate the AF burden. Another thing added is atrial cardiomyopathy. Most of these patients, those who have atrial fibrillation, continued, recurrent, going in and out, they develop functional change, electrical change in the atria and develop atrial cardiomyopathy. And this group of the patient again have a poor prognosis and they go for more difficult times. Then next one is, we say already that Cardiovascular score 2, class 1. Cardiovascular score 1 also can be given as class 2A. In cardiomyopathy, class 1, you have to anticoagulate them. Device detected, class 2B. Check this, assess the patient, anticoagulate them because they carry high risk of going in future intermittent without your knowledge, and they will end up in probably embolic stroke. Another thing we came whether in cases of rhythm control, when you want to rhythm control acute or worsening symptoms is a class 1. All are this is class 1. But what they have said, when you plan a scheduled cardioversion, must anticoagulate minimum 3 weeks. If not, probably do transesophageal echo. Thus they have come to. Transesophageal echo is as a class 1, 3 weeks anticoagulation class 1. So all this need to be done. continuation of anticoagulation after your cardioversion, minimum 4 weeks. So this is also has been a stress. But when you do ablation, then after ablation, whether it's successful or non-successful, continued your anticoagulation for 2 months, 8 weeks is being recommended irrespective of CHA2DS2-VASc score. Does not matter what is his CHA2DS2-VASc score, but they need all 2 months. Then what is the more important in cases of percutaneous intervention? When you're planning to do this one and you think patient is high risk for bleeding, in those group of patients, you can reduce the dose depending on this, those who are going for DOAC and there's and duration of their antiplatelet measures will be like minimum 1 week, class 1. If you want to give up to 1 month, class 2A is not class 1 anymore. So up to 1 month, they say 1 week is more than enough. Remove the aspirin, continue with other and they remove. So what they have come out with this same guideline, which was there in before, and to simplify it, you can see it like this. Acute coronary syndrome, maximum up to 12 months, any of this antiplatelet. Anticoagulation will continue lifelong. Anticoagulation in both will continue lifelong, but if it is a standard where there is a not acute event, then up to 6 months is more than enough. So almost same guideline with little stress, remove the aspirin fast. You don't need to give aspirin longer, except if burden is very high. In last few slides, so they have come out to compare like physical activity, all these things was class 2. Now they're going to all class 1. Alcohol consumption reduced to only 3 drinks per week, class 1. Very strong recommendation. Catheter ablation as a first line, change from 2A to 1A as a primary treatment. So these patients with AF, they comes is all class 1. Similarly, concomitant AF ablation from 2A, now class 1A. Ablation has jumped to as a first line treatment. Weight reduction has also strongly come. Anything ager than this, they have to come out with very fast. So in last, this is, yes, body weight 60 has come out. So use of bleeding scores has been removed. HESPLED score is no more has been used. And this is IV flecainide and amiodarone has been reduced. So this is the last slide. And so this is the last slide, anticoagulation. We have to compare with patient if it is on of the drugs. So one should carefully watch for those drugs he is coming. And in conclusion, ladies and gentlemen, as we know that atrial fibrillation guideline has now strongly recommending comorbidity and risk factor management. We have to avoid stroke in these cases. Better symptom anticoagulation is early. CHA2DS2-VASc score 0 only has been removed. Rest all need to be anticoagulated. Female sex and HESPLED score has been removed. And patient don't switch from one dog to another dog unless there is a real indication for it. What they have come out that unfortunately in this guideline, what is not been given, what is not been given is which case you select for rhythm control or the rate control is not been specified. Thank you.
That was a good sum up, Doctor.
I think question answer session will keep for the last. And our next speaker is Dr. Georgie Kosi. But physically he's not present, so we'll display the recorded session here. The topic is the chronic coronary syndrome ESC 2024 guidelines.
Good evening. I will be presenting the 2024 ESC guidelines for chronic coronary syndrome in brief with the key highlights. So, in 2024, the ESC guidelines redefined chronic coronary syndrome beyond just fixed atherosclerosis. There was an enhanced focus on both microvascular and microvascular coronary conditions, and it incorporated patient-centric approaches for improving the management. So CCS now also includes angina and ischemia with non-obstructive coronary arteries, has been labeled as ANOCA and INOCA. It recognizes the functional abnormalities beyond just fixed stenosis. So the spectrum ranges from fixed stenosis at the macrovascular level all the way up to microvascular conditions. And although stable for a long period of time, chronic coronary diseases are frequently progressive and may destabilize at any moment and develop into an ACS. Clinical presentation of chronic coronary syndrome ranges from chest pain, stress-induced, to asymptomatic, to LV dysfunction due to ischemic origin. The causes and main mechanisms are, from the epicardial side, structural due to a fixed defect, stabilized intramural hematoma, myocardial bridge, or coronary aneurysm, and functional epicardial vasospasm or autonomic dysregulation. From a microvascular perspective, it can be functional with impaired vasodilatation and or increased vasoconstriction, structural like intravascular plugging, perivascular fibrosis, extramural compression due to myocardial hypertrophy. Management of CCS would be a four-step approach, starting with general clinical evaluation, examination by a cardiac specialist, advanced diagnostic testing, and then management and planning. Careful and detailed history taking is the initial step for diagnosing CCS. Although chest pain or discomfort is the cardinal symptom of CCS, most patients do not necessarily present with this. 10 to 25% of patients in contemporary studies with suspected CCS have actually presented with angina, and 10 to 15% have shortness of breath or dyspnea, while 57 to 78% have anginal quality pain. People with suspected obstructive coronary artery disease, we are familiar with the pretest probability model that we use. However, two simple models that include clinical risk factors, which is the RFCL model, which takes into account family history, smoking, dyslipidemia, hypertension, diabetes, and the CAC score algorithm, which goes a step further by incorporating the calcium score into the risk model, have shown to identify 2.5 to 3.5 times more patients who didn't need or didn't stand to benefit from further diagnostic testing. So the scoring for the RFCL scoring would first consider the symptom score, 0 to 3 points, and then consider the number of risk factors, and then chart it out based on age to reach a degree or percentage of risk for CCS. So the recommendation by ESC is to estimate the pretest likelihood of obstructive CAD. It is recommended to use additional clinical data like any other peripheral vascular disease, resting ECG, echo findings to see if there is an increase in the risk. If the individual is at a very low risk, less than 5%, further diagnostic testing can be considered. With a low risk of 5 to 15%, coronary calcium score is to be considered, and individuals with initially low risk of 5 to 15% of obstructive CAD, exercise ECG, detection of atherosclerotic artery disease and non-coronary arteries may be considered to adjust the pre-test likelihood. Stress test, due to its low sensitivity and specificity, has a very low diagnostic performance, but in the lack of availability of other imaging tests, EAC recommends that it can be considered to refine the risk stratification. But stress test in individuals with a low or moderate, that's 5 to 50% pre-test likelihood of obstructive CAD, is not recommended as per them to rule out CAD if CT coronary angiogram is available. The CACS model can be used to further enhance the risk stratification if the RFCL model is not meeting or is sub-criteria. With incorporation of the calcium score, this gives us a better picture of the patient's risk and potential underlying CAD. So putting it all together, patients with very low risk of less than 5% defer any further testing. Low risk 5 to 15%, adjust the clinical likelihood or consider CT-CA. Moderate risk 5 to 15%, 5 to 50%, sorry, CT-CA or functional imaging like PET scan, CMR, or stress echo. Patients at high risk, functional imaging, PET scan, CMR, stress echo. And only patients at a very high risk, more than 85%, should be considered for invasive coronary angiography as per the ESC guidelines. When non-invasive tests are inconclusive or not performed, identifying the artery which is responsible for the ischemia, especially in a multivessel coronary artery disease situation, can be challenging. The FFR and IFR correlate poorly with the diameter stenosis by visual assessment. If the visual assessment of 40 to 50% stenosis, only 31% were hemodynamically significant. And on the other end of the spectrum, 71 to 90%, 20% were not significant. Only an estimated diameter of more than 90% predicted hemodynamic relevance with high accuracy. So as a result, the optimal angiographic cutoff value for non-significant stenosis is 43% for the left main and 55% for other vessels. So this implies that the threshold for doing a functional assessment for larger arteries should be set at 40% of diameter stenosis. So after confirmation of the diagnosis of first line of testing, all patients should receive lifestyle and risk factor modification recommendation and disease modifying and anti-anginal therapy. The ischemia trial showed that an early revascularization strategy did not yield a short-term survival benefit in patients without left main disease, nor reduce LVEF. And with moderate to severe ischemia and non-invasive testing suggesting that most patients should initially be treated conservatively with optimized medical management. Patients can be referred for coronary angiogram if CT coronary angiogram detects a more than 50% stenosis of the left main, 2 or 3 vessel disease, which includes a proximal LAD with more than 70% stenosis, or if any of the functional imaging shows moderate to severe ischemia involving an extensive part of the myocardium. So here is the diagnostic algorithm to treat angina with non-obstructive coronary arteries. After the initial clinical evaluation and further cardiac evaluation, after we have a potential diagnosis of ANOCA, treatment for the same should be initiated. And failing symptoms disappearing, probably invasive coronary functional testing should be proceeded with. So the treatment for ANOCA is basically initiate lifestyle, nutrition, exercise, stress management, weight management, smoking cessation, modifying risk factors, then the medical treatment based on pathophysiological endotypes, mostly involving beta blockers, calcium channel blockers, and anti-anginal medications such as ranitidine, trimetazidine, ivabradine, depending on abnormal vasodilatation or abnormal vasoconstriction. Though it's difficult to cover the entire ESC guidelines, here are a few key messages. First, it is unclear if screening the general population for subclinical or asymptomatic obstructive coronary artery disease is useful at all. The role of antithrombotic therapy in CCS with ANOCA still remains to be established. There is no clear evidence that nitrates, ranitidine, nicorandil, and other drug of its kind or their combinations improve anginal symptoms more than beta blockers or calcium channel blockers. Long-term effects of beta blocker therapy in post-MI patients without reduced LV function still remains to be elucidated. In view of the reported positive impact of low-dose colchicine in patients with CCS, more evidence needs to be gathered if other subsets of coronary artery disease may benefit from colchicine. The impact of early revascularization and medical management versus contemporary GDMT on all-cause effects and cardiac MACE in patients with CCS ideally needs to be tested in a well-designed, adequately powered randomized trial. Complete revascularization of multivessel coronary artery disease by PCI can be achieved in a single procedure. In the setting of CCS, the value of a staged PCI and the optimal interval between staged PCI needs to be evaluated. Whether CABG surgery and PCI are comparable among patients with ischemic cardiomyopathy and heart failure with reduced ejection fraction in the modern era of heart failure treatment needs to be assessed. Among patients suitable for off-pump CABG with complex multivessel CAD, but no left main CAD, the impact of hybrid revascularization on outcomes needs more investigation. The medical therapy of ANOCA is largely empirical. Therefore, prospective randomized clinical trials are needed to determine the efficiency of anti-anginal treatment in improving symptoms and outcomes for the different endotypes. There is also a need for further evidence on the effectiveness of neuromodulation, spinal cord stimulation, angiogenesis, coronary sinus occlusion in patients who suffer from refractory angina.
Thank you.
Thank you all for the attention, and unfortunately I couldn't be there in person. Hope you have all enjoyed the conference till now.
So the last speaker of the session will be speaking on hypertrophic cardiomyopathy as per ACC 2024 guideline is Dr. Murali Krishna, a personal friend and a very senior intervention cardiologist working at Prime Hospital, Dubai. Over to you.
Good evening, everybody. The chairman of Shakeheart, he has very clearly elucidated that 10 key points should be given for this session. So I start off my talk. This one? Oh, okay. As we all know, hypertrophic cardiomyopathy is a genetic disease, but almost 40% of people may not have a genetic variant. It's usually because of a sarcomere genotype variation that hypertrophic cardiomyopathy causes all its manifestations, and both structural as well as clinical manifestations, which include sudden cardiac death. Now, the importance of hypertrophic cardiomyopathy has been highlighted recently after the advent of magnetic resonance imaging and other genetic studies, which has proved beyond doubt that we can prevent and manage hypertrophic cardiomyopathy in a much better fashion than before. The first take-home message given, I'll be talking about the ACC guidelines because that is the latest 2024 guidelines for hypertrophic cardiomyopathy. So I'm just summarizing 10 key points here. The first and foremost point, what they have mentioned, is that the shared decision-making is essential to provide the best clinical care. Involve patients, families, and their care team in all decisions, because this involves a genetic component, and there could be a reason that, you know, the children could also be involved, because they also could get hypertrophic cardiomyopathy later on in life. The second take-home message is that the primary cardiology team can initiate, evaluate, treat, and continue the longitudinal care of such patients. However, a multidisciplinary hypertrophic cardiomyopathy centers with appropriate expertise can be important to optimize care for patients with hypertrophic cardiomyopathy. By this statement, what they mean is that there are new therapies, which, like the old therapies, which includes a decision to do a ICD, an implantable cardioverter defibrillator, interpret the genetic tests, and also do treatments like septal ablation. All this needs dedicated multidisciplinary care center. So, the multidisciplinary hypertrophic cardiomyopathy team should be involved in challenging treatment decisions, which I already elucidated, and where reasonable alternatives exist, like the decision for ICD and all that, where the strength of recommendation is weak. Example, any decision relying on a class of recommendation which is 2B or less. We need to talk to multiple people and then take a decision. The decision is particularly nuanced. Example, interpretation of the genetic testing, whether primary prevention with implantable cardioverter defibrillator decision making. All this should involve the dedicated center. And of course, the hypertrophic cardiomyopathy specific invasive procedures, which I also elucidated earlier. The take-home message 3 is that careful ascertainment of family history is very important, and this includes for sudden cardiac death. Counseling patients with hypertrophic cardiomyopathy about the potential for genetic transmission of hypertrophic cardiomyopathy to their offspring. The options for genetic testing and the cornerstones of care, which includes maybe an ICD implantation. The other message is that assessing a patient's risk for sudden cardiac death is an important component of management. So there are parameters which we assess to decide what is the next, what is the incidence of a patient having a sudden cardiac death in the next 5 years, and that depends on certain functional, clinical and structural findings. And this decision making regarding implantable cardioverter defibrillator placement has to be made based on this SCD assessment. The take-home message 5 is that the risk factors for sudden cardiac death in children. Now there is a dedicated full-fledged chapter for children with hypertrophic cardiomyopathy in the new guidelines. The risk factors for sudden cardiac death in children with hypertrophic cardiomyopathy carry different weights and components than those used in the adult patients. The threshold for ICD implantation in children often differs from adults. And new risk calculators specific to children and adolescents have been validated and can help young patients and their families contextualize their estimated risk of sudden cardiac death. The new drug which is available for hypertrophic cardiomyopathy is a cardiac myosin inhibitor. It is used only for obstructive hypertrophic cardiomyopathy where there is an outflow tract obstruction, which is more than 50 millimeters mercury. The drug inhibits the actin-myosin interaction and this helps in decreasing the cardiac contractility and reducing the left ventricular outflow tract obstruction. The only drug which is FDA approved is called mavacamten, and this is available for use in specific cases. Now, these agents can be beneficial for patients with obstructive hypertrophic cardiomyopathy who do not derive adequate symptomatic relief from the usual first-line drugs. The first-line drugs are usually beta blockers, non-dihydropyridine calcium channel blockers, and of course, disopyramide. Now, the invasive treatment, which includes septal reduction therapies either by surgical myomectomy or by alcohol septal ablation, these can be performed in obstructive hypertrophic cardiomyopathy when performed by experienced HCM teams at dedicated centers. And they provide a very safe and effective symptomatic relief for patients with drug refractory or severe outflow tract obstruction. The take-home message 8 is that patients with HOCM and persistent or paroxysmal atrial fibrillation have a sufficiently increased risk of stroke. So AF is a very important component in hypertrophic cardiomyopathy at a later stage. And they have to be treated with oral anticoagulants. And you should consider oral anticoagulants or warfarin. The new oral anticoagulants or warfarin should be considered the default treatment option irrespective of the CHATS score. And because rapid atrial fibrillation is often poorly tolerated in patients with hypertrophic cardiomyopathy, maintenance of sinus rhythm and rate control are key treatment goals. Exercise stress testing is a very helpful in determining overall exercise tolerance and for latent exercise provoked left ventricular outflow tract obstruction. And in children, because they may not be aware of symptoms or they may not describe symptoms readily, routine exercise testing can be particularly important for younger patients. And increasingly, data affirm that the beneficial effects of exercise on general health are extended to patients with hypertrophic cardiomyopathy. So patients with hypertrophic cardiomyopathy should exercise. Now, healthy recreational activities, whether it can be light, moderate, or vigorous, has not been associated with increased risk of ventricular arrhythmia events in the short-term studies. So patients should be encouraged to exercise, but of course, individual variations are there depending on the amount of left ventricular outflow tract obstruction and other parameters. Now, what is new in the 2024 guidelines compared with the older guidelines? The revised is about the heart rhythm assessment. Now it is a class 1 level of recommendation, and earlier it was a class 2A. So in patients with hypertrophic cardiomyopathy who are deemed to be at high risk for developing atrial fibrillation, based on the presence of risk factors or as determined by a validated risk score and who are eligible for anticoagulation, extended ambulatory monitoring is recommended to screen for AF as part of initial evaluation and annual follow-up. So it is a must now. It's a class 1 recommendation. And exercise stress testing, which was not a recommendation before, is now a class 1 recommendation, especially in pediatric patients. The other one revised is both are 2A, that for patients with hypertrophic cardiomyopathy with more than one major sudden cardiac death risk factor, discussion of the estimated 5-year sudden cardiac death risk and mortality rates can be useful during the shared decision making process for ICD placement. The other one is again revised, is about the recommendation, the pharmacological management of symptomatic patients with obstructive cardiomyopathy. The new drug has been incorporated now. One new recommendation is management of patients with non-obstructive hypertrophic cardiomyopathy with preserved ejection fraction. So it is a class 2B recommendation now that for younger, less than 45 years of age patients with non-obstructive hypertrophic cardiomyopathy due to a pathogenic or likely pathogenic cardiac sarcomere genetic variant and a mild phenotype, valsartan may be beneficial to show adverse cardiac remodeling. The next one, again, a new recommendation is patients with hypertrophic cardiomyopathy who developed persistent systolic dysfunction. The new cardiac myosin inhibitors are contraindicated. It should not be used. And of course, the revised guideline is that one of them has become 2A, is that for patients with hypertrophic cardiomyopathy, participation in vigorous recreational activities is reasonable after an annual comprehensive evaluation and shared decision making with an expert professional who balances potential benefits and risk. And this I have already mentioned. So with that, we summarize the new 2024 guidelines. Thank you.
Sharma.
and just finished on time. And I think any question and answer, they can be done after we finish off, because we are already running short of time with one more session to go. Over to Dr. Brajesh Mittal. And with
Thank
this,
you.
I conclude this session.
Thank you, all the moderators and the speakers. I think that was one of the best sessions in a way that the most recent guidelines, one after the other, the main points were highlighted, and we got to know a lot in this. So, without further delay, we have the last session, and I actually sincerely thank you all for being available even for the last session. This is going to be another keynote session, and this session we have two lectures. So, as a session director, since Dr. Lochan is not there, I invite Dr. Srinivas Kumar to be the director of the session. Besides that, Dr. Thayer is here. Dr. Thayer Kazim is also, I saw him outside. Maybe he will join later. Dr. Sunil Modi. Please come over here. And so we have two online presentations. Both are Dr. Srinivas, both are recorded. Dr. Srinivas, both presentations are recorded, but both are available on live with us, both the speakers. So over to you. Thank you.
Thank you. I think good evening, all of you. I really appreciate all of your patience for staying.
There is a very quick announcement, sorry to interrupt, that we have put in some draws, and after this session, we will open the draws, 3 draws, which are one night stay for a couple, and all 3 are same draws. So 3 draws will be opened. Thank you so much.
Right. Thank you again. And then we come to last session, keynote lectures, but it's a very important keynote lectures coming up. So I request all of you to be awake and listen to this Dr. Fayashal and Dr. Roberts lectures on important aspects. We grew up seeing Dr. Fayashal. He was very dynamic interventional cardiologist from before, from Kashmir, India, and brought India good name. Thank you, Dr. Mittal sir, for arranging these talks. The first talk will be on unstable hemodynamics in ACS patient management strategies. We had a bird's eye view about this, how the new mix and other devices are helping us in performing patient surveys in acute coronary syndrome interventions with unstable hemodynamics. I think you'll hear more about it from Dr. Fayashal. I think, can you play the recorded lectures?
Dr. Shawl is,
can you? Is there live also?
Okay.
Also.
Thank you, Dr. Mittal, for your kind invitation. I'll be talking about unstable hemodynamics in patients with acute coronary syndrome, how to manage them in the cath lab. I have no financial disclosures to make. What patients are we talking about who may have a hemodynamic compromise in the cath lab? I'm talking about patients with complex coronary anatomy, which includes multivessel coronary disease, left main stenosis, as well as patients with hemodynamic compromise when they have low ejection fraction, which has been described as 35% or lower, particularly when associated with heart failure or the right heart catheterization shows high pulmonary capillary wedge pressure, or there is very high LVDP, as well as patient comorbidities. I'm talking most patients who have got acute myocardial infarction with severe cardiac shock, which may be complicated by cardiac arrest, LV failure, with complex lesions where you have to use some kind of rotoablation with low EF, or associated valvular disease. Now, these are the patients who have to be careful because they may develop some hemodynamic compromise. So, what kind of hemodynamics they will need in the cath lab when they have hemodynamic issues? Well, it will depend on the severity of the hemodynamic compromise. I think in a patient who's low risk, has some drop in blood pressure, but is not hypovolemic, we can use small dose of inotropes, particularly norepinephrine. But if patient has more hemodynamic compromise, we should then start them on a intra balloon pump. Although, as you know, there's a lot of controversies. It is good, it is not good. But I think in many cases, you can use an intra balloon pump in the cath lab for these patients, particularly when they have a good rhythm and they are not hypovolemic. But if patients in severe coordinated shock, I think one has to consider escalating the support to Impala CP. In fact, the recent trial on Impala CP in patients with acute myocardial infarction complicated by coordinated shock demonstrated higher survival in selected patients. And now ACC has given it class 2A indication for the use of Impala CP in selected patients with acute MI complicated by coordinated shock. But I'm going to focus my next 16 to 17 minutes on patients who are at very high risk of death. Mortality is high. They're in severe shock, complicated by cardiac arrest, undergoing chest compression and not responding. I think in those cases, the best hemodynamic support is an ECMO. Yes, you can use also Impala 5.0, but it's more complex. You can't really use Impala 5.0 because of its large size in an acute setting. So let's talk more about the ECMO in such patients. ECMO is available in every hospital where they have an open heart program. And now, how do we proceed with a patient who has no intrinsic rhythm? They're asystolic or recurrent VT, or PA arrest, and patient undergoing CPR with chest compression and is not responding, what I call when death is imminent. How do we approach such patients? Well, first and foremost is don't panic. Continue chest compression, blood pressure support, airway support, call for an extra hand, and quickly find the underlying etiology. And because if you don't treat the underlying problem, it's not going to work, even if you use ECMO or any kind of hemodynamic support. And while we are doing that, you get the what is available hemodynamic support in the cath lab. So when they are going chest compression, of course you have to intubate the patient. You continue chest compression while you get ready for cardiac bypass support. I'm talking about ECMO. What you can do is, because we use percutaneously 17 French for arterial and venous is 90 to 21 French. So what you do is, if you are already in the cath lab, you already have catheters in and patients arrested. If they have a good anatomy, you can just change the arterial and venous catheters for the ECMO. But what I do is, somebody is having a cardiac arrest and there's no access, I like to use ultrasound guided access to get these catheters in. So once they are on ECMO, the flow rate has to be at least 15 mils per kilogram per minute. And then after the patient is stable, then you do an angiogram, because in most have non-pulsatile flow. It's better to use a contralateral femoral access if you can. And then you do an angiogram, intervene or re-intervene, or if the anatomy is not suitable, they can go on to surgery while on ECMO. Now, this is the ECMO which I use, the portable ECMO. It can augment cardiac output up to 4.5 liters per minute. It can be used to support the circulation up to several weeks. And the good thing is, it does not require a stable cardiac rhythm for optimal function. But it has potentially a lot of disadvantages, not available in everywhere, not available in every hospital, non-pulsatile flow. And the problem with the ECMO is, if you use for a long time, it dilates the ventricle, it increases the afterload, so you have to unload these left ventricles. Otherwise, they get LV distension, pulmonary hypertension, and even thrombus formation and poor coronary and cerebral circulation. So, and also these catheters are large, 17 French per arterial, you can cause ischemia, as has been shown in the danger shock trial with Impala with 14 French. There were significant vascular complication. That's why when I put somebody on ECMO, I do an angiogram first to make sure we're about the bifurcation and is a good size common femoral artery to access it. And also, when you develop this distension of the LV because of long ECMO use, as I will show you later in a case example, that we have to unload his ventricles. Let me give you an example of this patient here who is just 60 years old, comes to emergency room with acute STEMI. You can see marked ST elevation both anterolaterally, both anteriorly as well as inferiorly. So of course a STEMI, patient was taken to the cath lab, but on the way to cath lab, patient had a cardiac arrest, was a PA arrest, did not respond to resuscitation efforts, epinephrine, chest compression. So you can see on the fluoro, the chest compression is going on while I got the access by ultrasound in the femoral vein and artery. And this is the cannula in the right atrium. And this is after the patient is stable on ECMO. We did the angiogram from the contralateral groin axis. You can see the left side is clean. What this patient had was an occluded, large right coronary artery. It just tells you a single vessel can kill you. So rest was easy, patient stable, normal rhythm, very easy to do this intervention, and which was done very quickly. And then after that, we did an LV gram. You can see here, preserved LV function and just mild hypokinetic inferior wall. Since this was a short ECMO support, single vessel, patient was taken off the ECMO in the cath lab and was discharged 3 days later. Now, let's go to a second case, which is somewhat more complex and different. It's a patient who developed cardiac arrest in the operating room before coronary bypass graft surgery after the induction of anesthesia. The history is a 63-year-old gentleman who was scheduled for an elective bypass graft surgery for his left main osteal lesion and the chronically occluded right coronary artery. It was an elective case. So patient was supposed to come for surgery, but 3 days prior to elective CABG, he comes to the hospital with prolonged chest pain, with new EKG changes. In the emergency room, he rapidly deteriorated with heart failure, soft blood pressure. He was intubated, and since he was already scheduled for surgery, he was transferred to the operating room for urgent CABG because of his known left main and right coronary CTO. Now, this was his electrocardiogram prior to his emergency CABG. You can see here marked ST elevation AVR. You know what that means is when you have AVR, ST elevation, either there is severe three-vessel disease or the left main occlusion. So, as he said, he went to surgery, but before they opened the chest, after he was given anesthesia, he developed refractory cardiac arrest due to recurrent VT, recurrent VF, multiple shocks, and he was placed on ECMO while the CPR was processed, so he became then totally dependent on ECMO, and the TE was done in the operating room that showed severe LV dysfunction, 15 to 20% EF, and the surgeon decided that we should not proceed for bypass graft surgery, given his known anatomy of left main ostium, he should be sent to intervention to the left main. Well, as you know, for decades and decades, it is the surgeon who bails us out, we as interventionists, if there's a problem. Here, this is other way around, and the surgeon referred back to the cath lab, this patient. But let me put it this way, we have a heart team approach. You always do what is best for the patient. I think in this case, knowing he has a left main occlusion from his known anatomy, it was not unreasonable to send him to surgery, in surgery after cardiac arrest, to send him to PCI to the left main. So I brought him down to the cath lab. You can see here on the right side, there is the arterial cannula and the venous cannula. We got the access from the left femoral artery, left common femoral, and we did the angiogram. Now, as expected from the electrocardiogram and known CT of the RCA, he has occlusion of the left main and very poor flow, and despite on ECMO. And what is interesting here, you see the contrast. The contrast is in the sinuses and is delayed resolution of the contrast. What that means is that this patient has no LV or left ventricular ejection. He is totally dependent on ECMO. No LV ejection, but non-pulsatile flow. The rest was easy. Patient stable. We have a guide catheter in. We crossed with the wire. Did the left main ostial stenting. We got beautiful results, and we did the IVS post. We showed a 10.6 millimeter square IVS area. And then after this procedure, as he said that he was going to stay on ECMO for a while. We know ECMO can cause for long periods increase in the afterload, increase LVDP. So we put balloon pump from the contralateral groin, which we had used for PCI. We put a balloon pump as an unloading agent, and you can see his blood pressure is 110/60 on ECMO and IABP, and ECMO flow was just 3 liters a minute. So he was taken to ICU. This is the EKG pulse, showed marked improvement on his electrocardiogram after left main PCI. And then next day, he's awake with excellent chest X-ray, excellent oxygenation, the normal urinary output, no increase in creatinine, but he could not be weaned off ECMO. And we did the echo. Echo shows dilated LV, poor LV function, 10 to 15% EF. You know what is happening here. He's on ECMO dependent, and we need to unload his ventricle, and the intra-aortic balloon pump is not helping. So what we did is we removed the intra-aortic balloon pump and used an Impala CP, which is a much more stronger unloading agent for left ventricle. We were on Impala, we were able to wean him off the ECMO, and then after 5 days, he was off the Impala. So when you use Impala and ECMO, we call it ECPALA. We were very lucky that he was discharged 2 weeks later home with an ejection fraction of about 40%. You can see here from 10 to 15%, almost thick walls and good apical function. So it's almost 40 to 45% ejection fraction. So just quickly about the importance of left ventricular unloading can lower the mortality. This is a curve showing that when you're on just ECMO alone, as compared to ECMO and Impala, there is much improved survival. When you use what we call ECMALA or ECMO and Impala for these patients who had a prolonged duration of ECMO support, they need to have unloading of the left ventricle. There's another study done where they show that as compared to ECMO alone, the survival gets better with balloon pump and ECMO. But no question, when you have Impala and ECMO, they are much better survival in these patients who had a long ECMO support. So this is just a quick look, the role of ECMO, or what I used to call CPS, cardiopulmonary bypass support, or ECMO, in patients in cardiac arrest in the cath lab. We looked at our 23,000 patients, and what we found was that out of these 23,000 patients, 39 required emergency ECMO, and of those 39, 10 went to surgery, 7 survived, 29 had intervention, and 24 survived. In other words, out of 39 lives, 31 were discharged. So I'd like to conclude that the type of hemodynamic support depends on the hemodynamics of the patient. As I have shown you in these two cases, that when you have severe hemodynamic collapse, that the patient is requiring chest compression, ECMO appears to you the best support and best outcome only when instituted early, and of course followed by the definitive treatment. Current data, actually from the danger shock trial, shows that Impala CP is very useful for acute myocardial infarction and severe cardiac shock in selected patients. If you use the same criteria as danger shock trials, the first randomized trial is showing improved survival with the Impala CP, and also when patients are stable and the operator is more quieter and more, subdued with the sick people. So it makes a complex intervention easier when patient is stable. And actually, when patient is stable, they will likely receive complete revascularization. That's better long-term outcome. Thank you very much for your kind attention. I'll be happy to answer any questions.
Thank you, Dr. Fayashal, for an excellent talk. And hall, I don't know whether you could hear the applause from the hall. And the message of is online, no? Can you hear us, sir?
Yes.
Yeah.
Yeah, I can hear you.
Yeah. Thank you for an excellent talk. The message which you gave was never give up. And the team approach, and then operator being calm, and that helps a long way in recruiting. And these latest devices help us in achieving our goal. And but the thing is, it has to be done, instituted very fast without wasting time. The operator coolness and having anesthesia backup or critical care support, intubation, timely intubation, and supporting further also goes a long way. I think Dr. Shal is online for us. Anybody has any questions? We can have 1 or 2 questions, I was told by Dr. Mittal.
Yeah, thank you very much, Dr. Fayaz. Wonderful, and thank you for sharing very complex cases with us. So there are 2 comments from my side. The first one, if you have a patient with a cardiogenic shock and acute MI, always the question is coming, you do PCI first or mechanical circulatory support first? Which one you recommend from your experience? So this is the first question. The second question, we know that from the guidelines that mechanical circulatory support, routine mechanical circulatory support is class 3. So in which cases you would recommend immediate mechanical circulatory support? Thank you very much.
Answer to your first question. Can you hear me?
Yes. We can hear you, sir. Please go.
The first question is, when you are in cardiac shock, first and foremost, the patient has to be stable. I would not intervene. Whether you want to put a balloon pump or whatever you want to do it, patient has to be stable first, and then you do the intervention. Because you can't do in a rush intervention while the patient's having hypertension. You have to make patient stable hemodynamics. I mean, their blood pressure has to be better, the oxygenation has to be better, because that can prevent other issues. The other question you asked me about, in what kind of support you meant to use, right? What kind of support you use, Dr. Pai?
No, which
Yeah.
MI patients of shock you decide to, how to decide to put them on an impeller? That's what is the question.
Okay. I think if there are stages of shock, if you look Sky classification, there is stages of shock. But although we have now danger shock trials showing improved survival if you initiate early Impala CP followed by the revascularization. But I think if some first and foremost, we like to know their left ventricular end-diastolic pressure, LVDP or right heart catheterization, to make sure they're not hypovolemic. And then if somebody really is in early shock, and I don't want to push for Impala, you can put a balloon pump, although there's a lot of controversy, but I would not proceed further till I see patient is somewhat stable, whether you had to use a small dose of inotropes like norepinephrine and use a balloon pump. And if somebody is extreme shock, I'm talking like with the danger shock trial, blood pressure in 60s, inotropic agent, I think if you have Impala CP available, that's the best treatment. We have now first randomized trial to show improved survival in these patients. But importantly, in the trial, 20% had vascular complication. So when I access the groin above the bifurcation, you want to make sure there's a good lumen, at least 5 to 60 millimeter common femoral artery before you put the 14 French in. Again, support first, then the intervention.
Perfectly okay. I mean, I know we've been using ECMO, and some of these patients do very well after ECMO. I mean, they're extremely sick patients, and as you said rightly, imminent death patients. So whatever is possible has to be done.
The second part of the question of Dr. Shal was regarding usage. We still keep using IABP in spite of it being reported in guidelines as class 3. I think, Hope, you also showed in the case where you used IABP. I think we clinicians still take the help of IABP in some situations. Hope you agree with us. What are your thoughts?
I think if you see a patient in early stages and initiate balloon pump early, and they are not hypovolemic, and their rhythm is stable, it does work. I mean, if you look at some of the trials, there was one from British Society that people who had revascularization on a balloon pump did not have initially any improved survival, but long term they did better. Because the key thing is patient has to remain stable before you put a wire across the lesion, do intervention. You have to, and it is freely available. I would recommend if you have a balloon pump, put it in.
I think we lost him.
Can you hear that?
Voice got.
Can you hear? I can hear you. I can hear you.
Yeah. Yeah, the last part of your answer we missed out, sir. The sound was breaking.
Oh.
Can you repeat?
Can you hear me now?
Yeah, we can hear
Can
you
hear me
now.
now?
So we are
I
losing
can hear you, but can you hear me?
Yes. We can hear you,
You
sir.
can hear
Please
me?
complete the answer.
Okay. What I meant was that if you have a patient who comes to in a real from the emergency room to cath lab is hypotensive, just put the balloon pump first. Don't wait. Hey, let me do an angiogram. No. Put the balloon pump first, and then do the angiogram.
Thank you, sir. I think we had an excellent talk by you, and the message is never give up. And many times life is important. If you put all your efforts, then many times patients could recover. A great message from a very senior interventional cardiologist, the source of inspiration to a lot of us. Thank you, sir. I think
Thank you.
a big round of applause to Dr. Fayaz Shal. I think entire hall waiting
Thank you,
will
Dr.
eagerly.
Shah.
Thank you.
Dr.
Thank
Shah,
Thank you, Dr. Mittal.
And thank you for joining on Sunday morning. So we
Oh,
are.
no, my pleasure, my pleasure.
Thank you.
Thank you, sir. We'll
Thank
go to the next lecture.
Yes, we carry on with the next.
The next one is something related with NOACs, I think.
Liano is a TIMI trialist.
Okay.
Working on a new agent. So next speaker is Professor Gugliano. He is one of the TIMI trialist member. He has conducted a very, very large number of trials of the TIMI type. And his presentation is also recorded. He will be presenting on a newer therapy, newer drug, which he has been working upon. He will be available online as well. I do not know, is he there? Yes, he is already online, and now can we say hello to him?
Hi there. Good evening.
Yeah, hi.
Good to see you, Brajesh.
Thank you. Good to see you. Good morning. Good morning. It's a great pleasure to have you. We have a wonderful panel here. A lot of audience is still there, even in the end of the day. And I have Dr. Srinivas, the session director now, Dr. Sunil Modi from Delhi, Dr. Srinivas from Hyderabad, and Dr. Thayer from UAE. So we will start running your lecture, and then we will discuss.
Great. Thank you.
Okay.
Hello, my name is Robert Giuliano, and I'm a senior investigator with the TIMI Study Group, member of the Cardiovascular Medicine Division at the Brigham and Women's Hospital, where I both see outpatients and round in our cardiac intensive care unit, and I'm a professor of medicine at Harvard Medical School. And I want to thank once again the organizers of the Shakeheart conference to kindly have invited me and allow me to participate in this 9th annual 2025 conference. Today I'll be talking about an update on factor 10A and 11 inhibitors in atrial fibrillation. I want to cover 4 areas: the 2024 ESC guidelines that were recently released for management of patients with atrial fibrillation. I'll share with you some new findings from combined AF, a patient-level meta-analysis of the 4 DOAC versus warfarin trials. I'll also share a few highlights of ongoing research with lower doses of DOACs in atrial fibrillation. And I want to end with perhaps the most forward-looking and exciting topic of factor 11 inhibitors in atrial fibrillation. So with regard to the ESC guidelines, these were released last year. It's a large document, so I'll keep it brief. It has over 100 pages, over 1,200 references, 33 tables and figures, and some 72 new or revised recommendations. And among the most important of these I wanted to focus on is Class 1A, new recommendation, meaning you should do the following. Use direct oral anticoagulants in preference over VKAs in eligible patients with AF who are undergoing cardioversion to reduce the risk of stroke. On the other hand, one of the new Class 3B recommendations, meaning one should not do this, and that is do not use reduced doses of DOACs unless they meet the specific criteria for dose reduction, because otherwise you expose patients to a higher risk of thromboembolic events. Couple of other new recommendations. One is to continue oral anticoagulation. This is a Class 1C recommendation. Continue anticoagulation after AF ablation and after LA exclusion device placement, one or the other, or both, to prevent ischemic stroke and thromboembolism. And that's because even if you have a successful AF ablation, even if with placement of a LA exclusion device, patients remain at elevated risk for stroke. And then at the bottom, you see the recommendation for atrial flutter. Oral anticoagulation is recommended in patients with flutter to prevent risk of ischemic stroke and thromboembolism. The risk may be lower than patients with AF, but still deserve anticoagulation. And then one more Class 3 recommendation: one should not routinely use oral anticoagulants in patients with embolic stroke of unknown source, or ESUS, because in studies where patients had ESIS and were not in atrial fibrillation, there wasn't any clear benefit of giving an anticoagulant. And as you know, there is a risk of bleeding. So unless the patients in AF, do not give anticoagulants to patients with ESIS. Now I want to cover a few findings from the combined AF patient-level meta-analysis of the 4 DOAC versus warfarin trials. This is an effort I've been involved in for the last 5 years or so, combining patients across these large trials to try to better understand what we can about the comparison between DOACs and vitamin K antagonists. At the top line, the findings are that the DOACs, when you combine all 4 together compared to warfarin, reduced stroke or systemic embolism by 19%, reduced all-cause mortality by 8%, and tended to reduce major bleeding by 14%, although there you see a borderline p-value for significance, and there's also heterogeneity between the trials and between the drugs. Intracranial bleeding, on the other hand, was reduced by 55%, and this was true of all the 4 DOACs relative to warfarin, whereas the reduction in major bleeding was really only seen significantly with edoxaban or apixaban. Now, other endpoints of interest include an increased risk of GI bleeding with the DOACs without real heterogeneity across the trials and drugs. You see the hazard ratio of 1.58. However, overall, the net outcomes were significantly reduced with DOACs versus warfarin, a reduction of 11%. The group has now published 12 different papers. I'll highlight a few. Dr. Harrington published findings across the spectrum of renal function comparing DOACs versus warfarin. Dr. Agarwal, one of our fellows, validated the DOAC bleeding score, which is more accurate than the other existing scores to predict bleeding in DOACs. Dr. Patel from our group reported on outcomes with DOACs versus warfarin across the range of body mass and weight. The bottom line here was that lower body masses and weights, the DOACs really do quite well compared to warfarin, where at the high end, many of the endpoints were similar, and for some endpoints, warfarin appeared to do somewhat better than the DOACs at the very high body weight, or BMI, meaning BMI above 35 or even above 40. 2 biomarker papers, one from our current fellow Paul Haller, looking at a heart failure risk assessment using only biomarkers. BNP, troponin were the 2 most important, and GDF-15 also provided some prognostic information. And Lars Valentin, expanding on his prior work on the ABC risk score for ischemic stroke, which is a biomarker-based risk score in combination with some clinical factors. I want to now turn our attention to the lower dose DOAC regimens. There has been some interesting work ongoing here. We reported previously a comparison of the standard dose of regimen of edoxaban, so-called high-dose edoxaban regimen, or HDER, 60 milligrams dose reduced to 30 in selected patients, as compared to a lower dose regimen of edoxaban, LDER, 30 milligrams dose reduced to 15. You see here that edoxaban 30 milligrams reduced to 15 had a higher incidence of stroke or systemic embolism. It has a ratio of 1.31. The findings with major bleeding, however, go in the other direction. The lower dose regimen of edoxaban reduced major bleeding by 36%. The net outcomes, however, were pretty similar with edoxaban, and comparing these 2 regimens. I tend to prefer that middle one, the secondary net outcomes. These are really serious events, disabling stroke, life-threatening bleeding, or death. You see no significant difference between the 2. In a newer analysis, looking at patients over age 80, who did not have any dose reduction criteria, the label would say 60 milligrams is the dose here. We compared that to patients who had received 30 milligrams in the randomized trial. And you see that for stroke or systemic embolism, there was no significant difference statistically, although the hazard ratio favored the edoxaban 60 milligram dose. No difference in clinical outcomes. No difference in mortality, almost identical. But where there was a big difference in the old over 80 group was in major bleeding. It was higher with the edoxaban 60 milligram group, even though these patients didn't meet dose reduction criteria. The hazard ratio is 1.57. So consideration in practice, if patients aren't tolerating a standard dose of edoxaban and they're elderly over age 80, now we have information on what would happen if you prescribe 30 milligrams, which is currently off-label in these patients. And then lastly, on the factor 11A inhibitors, these are very exciting compounds because they allow us the potential to uncouple effects on hemostasis, which is affected with other drugs like DOACs and warfarin, versus thrombosis, forming a clot within an artery, which is really where factor 11As exhibit most of their effect. The factor 11A inhibitors don't affect hemostasis to nearly the same degree as other anticoagulants because of its place in the coagulation pathway. And we know this from genetic studies of patients with 11 deficiency, and also now from ongoing studies and experiences in surgeries. So there are multiple ways to inhibit factor 11. This slide shows you 5 of the drugs that have been in development. Some are monoclonal antibodies given by injection once monthly. There's one antisense oligonucleotide that can be given by sub-Q injections either weekly or monthly, and then 2 small molecule oral inhibitors that are given once or twice daily. With regard to the trials, I want to focus on 2 studies with reported results. A large phase 2 trial called Azalea, which enrolled 1,287 patients with atrial fibrillation at moderate to high risk of ischemic stroke. And this was performed by our group, the TIMI study group. And it was designed to see how abelacimab, 2 different doses, compared to standard dosing of rivaroxaban, with the goal of looking at bleeding, major, clinically relevant, non-major bleeding. Now, 1,287 patients is too small to assess efficacy. So the focus of this study is to look at bleeding and to determine, which dose should move forward. And what was found here was that both doses of abelacimab significantly reduced bleeding, the higher dose by 67%, the lower dose by over 3/4 compared to rivaroxaban. So marked reduction in bleeding. The higher dose regimen is now moved forward into a phase 3 trial called Lilac TIMI 76. Tell you more about that in a moment. There are also studies with the same compound in cancer-associated VTE, called Aster and Magnolia. The other 2 agents that have moved into phase 3 are asundexian in the OCEAN program and milvexian in the Librexia program. You see a number of studies in AF, secondary stroke prevention, and 1 study in acute coronary syndrome. Interesting and somewhat surprising results in the phase 3 Oceanic AF trial with oral asundexian compared to apixaban. This was a study in AF patients who either had prior stroke or multiple risk factors for stroke. Primary endpoint was stroke or systemic embolism, and they also looked at bleeding and net outcomes. However, during the trial, the Independent Data Monitoring Committee stopped the study early in November of 2023 after nearly 15,000 patients were enrolled. And the reason was they found that asundexian was inferior to apixaban to prevent stroke or systemic embolism. So on the 19th, the trial was stopped. Patients transitioned to open therapy and closed out the study. Of note, the same data monitoring committee recommended continuation of the stroke study that's ongoing in phase 3. Our group is also performing a phase 3 study with the monoclonal antibody abelacimab. And here is a different design. It's a placebo-controlled trial in 1,900 patients who are at high risk for AF but unsuitable for currently available anticoagulants. It's much like the elder care study done in Japan with edoxaban 15 milligrams versus placebo. The patients in Azalea are being randomized to abelacimab with monthly injections or placebo. The primary endpoint is stroke or systemic embolism and bleeding, in particular, specifically BARC 3C or 5, so very high serious levels of bleeding are the primary safety endpoint. That trial's enrolling, as is the Librexia AF trial with the oral compound milvexian. This is a study compared to apixaban in over 20,000 patients that is currently continuing to enroll. The primary endpoint is against stroke or systemic embolism. Bleeding is the principal safety endpoint based on the ISTH scale. The study started in April of 2023. It's estimated to run for a little over 4 years. So we look forward to these results. Now, what might we expect from the factor XIa inhibitors? Well, we have some early signals. It seems like inhibiting this target results in substantially less bleeding than the DOACs and less bleeding than warfarin. And they appear to be safe across a broad range of bleeding severity and locations and even procedures. However, to date, they seem to be somewhat less effective in reducing stroke than DOACs. They do have a proven efficacy in phase 2 with venous thromboembolism, and in the past with other development programs, this is translated into a reduction in stroke. And indeed, in Azalea TIMI 71, the stroke rates were quite low. In fact, 80% less than what was observed in patients on placebo or not anticoagulated. But as I showed you, one trial was stopped early with the oral compound asundexian. So we'll have to see how effective they are in reducing stroke. I believe it's unlikely that the factor XI inhibitors will be more effective than DOACs because the stroke rate's already pretty low and only some strokes are cardioembolic. It's possible that they could be relatively worse than the DOAC, and that might be related to the different target, the mechanism of action of these drugs, the potential, the potency of inhibition, and there may be differences even between the drugs because they're not identical. The factor XIa inhibitor abelacimab is targeted at maximal potency, so that's one that we'll be watching very carefully. Lastly, consideration for the net clinical benefit will be important here because it's possible that we'll have safety and efficacy signals that go in different directions. There's likely to be only small differences in stroke, but hopefully large reductions in bleeding. So time will tell, but keep your eye on this space. Thank you again for allowing me to participate in this conference, and I'm wishing you all the best.
Thank you so much, Professor Giuliano. And for the audience, Professor Giuliano is a TIMI trialist. He's a professor of medicine in Harvard, and he has been our honored speaker for last 4 years in the Shakeheart. It is early morning hours on Sunday, and he has taken all the pains to pre-record and being available now. So we can see you, Dr. Giuliano, and we have some panelists here. And Dr. P.K. Gupta will ask you a question. We open for discussion now.
Thanks for the excellent presentation. As the OSNIC-AF trial, it was withdrawn early because of the no net clinical benefit. But the pre-specified analysis have shown those who were DOAC naive perform better than those who were already receiving DOAC earlier. Is there any discrepancy? How you would like to explain this and whether the company will like to pursue it further or not?
It's a great question. Thank you. There was this curious finding in one of the subgroups based on whether patients had been experienced anticoagulants before or they were starting new for the first time. One can, after the fact, come up with various potential explanations, but I'm a little bit, I have reservations about that. It's not entirely clear why that wasn't seen in other development programs necessarily. And so I just, I'm not sure. It could be play of chance. The company, as I understand it, is not going forward, at least in this space of atrial fibrillation, to just target patients with prior experience. So I think that I don't know for sure whether it's real or not, but I think we'll need to move on to other compounds to really test this hypothesis for factor XI inhibition.
Thank you.
Thank you. Dr. Modi
I just
from
want
India.
to ask if it showed little less benefit in strokes. Is it possible that you use it for lower CHADS-VASc scoring just to avoid the bleeding because they are better off preventing bleeding and not so good for preventing the stroke? So, CHADS-VASc 1 or 2, these agents may be pursued.
Right. No, I think it's a good question, good point. What about the patient who has high risk of bleeding and low risk of stroke? And though that's uncommon, we certainly see those patients, the healthy elderly patients with atrial fibrillation. They may just on basis of age alone have a CHADS-VASc of 2. So yes, I think there would be space there. And the question will be, what's the extent of the trade-off? These days, stroke rates in patients who are on anticoagulation is very low, like 1% per year for a typical patient. Higher risk patients, obviously higher, but much lower than historic. So if these compounds dramatically reduce bleeding and you have a patient with high bleeding risk in front of you and low risk for stroke, maybe we would accept some loss of efficacy, because on an absolute basis, it might be a very small percent increased risk of stroke. So yes, I agree with you. I think I could see compounds be approved who have a favorable net outcome, who have a large reduction in bleeding, and maybe are not quite as good in preventing stroke. But it'll all come down to, what the trade-offs are and the actual numeric results.
Yeah. Yeah.
Doctor, in your clinical practice, what percentage of patients who are not fit for taking these NOACs and go for a LA appendage occluder procedures?
Yeah, no, this is a terrific question. And this explains why enrollment moves slowly in these types of trials. So we had the elder care trial done in Japan in elderly patients that took 3 years to enroll, just under 1,000 patients. Whereas you see these factor 11 inhibitor trials will enroll 10, 20,000 patients in a much shorter time period. These patients in practice seen by cardiologists are uncommon. I think I found 4 in my practice, 2 of whom ended up going for Watchman devices and 2 others who had, were very high risk, cancer or dialysis, et cetera. But we know these patients exist. They're often not referred to cardiologists because they don't want to or can't take an anticoagulant. So it's really the GPs and the primary care and the other non-cardiologists who are more likely to see these patients. Maybe they have a malignancy or, they have a bleeding disorder. Nonetheless, I mean, if you look at various surveys in multiple countries, it may be as many as half the patients with atrial fibrillation aren't on an anticoagulant. I think that's probably a high estimate, but they're not in the usual places. They don't come to our attention in cardiology. They rarely do, because why would they be referred to a cardiologist if they weren't even a candidate for an anticoagulant or a device? Yeah, it's a good point though, and very perceptive that it's a challenge to find these patients that are suitable for a clinical trial.
Thank you.
So, Professor Giuliano, thank you so much for presenting and being available online as always, and we expect you to be available year after year.
Yes, I hope to be there in person soon.
In person, most welcome.
Yeah, okay. Take care.
Thank you. Thank you so much. Thank you.
Bye-bye.
So friends, we are well within the time. Flight is boarded a few minutes earlier, and last few minutes are for a draw and vote of thanks. So first, my thanks to Dr. Srinivas for accepting to be director now for this session, and Dr. Modi and Dr. Thayer for this session. Thank you so much for your kind inputs and presence. Thank you so much. We should give a big hand to all the available faculty.